Okay, hi, Ralph.
Hi, Helmut. How are you?
Fine, and you?
Good, very good, actually. I think we're in a good shape to go. So we're gonna do this time a similar thing, to test it on YouTube
Yes?
in case something doesn't work. But obviously, I just wanted to have like a quick chat with you to see if it's okay for you to present the presentation,
Yeah.
because what we're gonna do is, and I can show it to you how it's gonna work. So basically, at first, it's gonna begin with this slide. There's gonna be a bit of music playing. And then I'm gonna go into, so basically for like 30 seconds when the live
Yeah.
starts, at exactly at 9 a.m. And then we go into this slide, which again, probably for around 30 seconds just to present your lectures.
Yeah.
And then I will hide it and you will see yourself on screen, which means that you can go.
Yeah.
Or you can give me like heads up if you're ready as
I do
well.
like this, yes.
Exactly. And then you can start presenting. So you can upload now the presentation here.
Oh,
What you need to do is upload slides.
yeah, I'll do it now.
Perfect. And then because you have two presentations, so if you want to
Yes.
have a break in between as well, like 20 seconds,
Yeah.
then I can show this slide again.
Okay.
And then you change your presentation. And then
Perfect.
you give me thumbs up. And then I put you back on screen.
Perfect. Now
That's
I'm
okay for you.
looking for the presentation on my desktop. This is one. Can I open two? Oh,
Yes,
I'm
of
not
course. You
sure.
can upload already to, whatever is easier.
Okay, then. Oh, this tells me I can only open a 50 megabyte PowerPoint presentation. It's very strange.
Okay. Well, in the worst case, if you have the PDF of that, you can upload the PDF.
Yes, but normally I present with PowerPoint.
Yeah.
I try again because before yesterday my lymphoma was of course also larger. It's very strange.
Maybe let me remove some of the
I'm trying.
presentation.
No, the lymphoma was not larger. So I can. This is 93 megabyte, and the system tells me it's only 50 the maximum.
Let me remove two presentations for you just to see if it's going to free some space.
Yeah.
Yeah, maybe if you can try now.
No, the system tells me again maximum 50 megabyte.
And do you have the PDF of that?
I have a PDF, yes. I have to put it on my computer from the pen. I have it here. It's always good.
Yeah, it's good to
have
do
everything.
these tests before, and just.
It's always good to have everything twice and 3 times and so on. Now, these two. And I go back here. And now I put the PDF on the desktop. Okay. And now, the other thing is, I'm uploading the document. The other possibility would be to share the screen. It's not good.
No, what you can do is, you can share screens, but also you can upload your slides. It's easier because then you can click through them, and then you will see yourself. When you share the screen, you don't see yourself. So basically, it's like,
Yeah,
when you do.
I see. Now I find the PDF, which is smaller. It's charging. No, the PDF is here. Should we try this now? Or should I charge the other one? Okay, this is here. And I move through the slides.
And then do you have an option of removing it yourself from the stream, or do you want me to remove it for you?
To remove what? Sorry?
So basically, when you finish the presentation,
Yes.
I can help you removing it. So
Yeah,
you
exactly.
say
This is fine. Yes, it would be
and then
perfect.
I put
Yeah,
this.
exactly.
And then you go with the second presentation.
Yes,
But
it's
yeah, and then I will add it to the stream for you.
Yeah, and this is fine. So now it's finished almost. 38. Okay, that's it. Now we have to go to page 1. I have to go down like this. It's the only way. Okay. Now I try to put the second. Let's see if it's possible to have 2. Because maybe
yeah, it should be. It should be.
Yeah. This I try now the PowerPoint if it accepts the maximum. It tells me I can only put 2 documents, but I put it only 1, so this would be the second. And he says, if you want to put more than 2, you should log in and registration.
Okay, that's weird.
Then we will do it after when you put my name, and then
exactly.
I will
put this so you have a bit of a break.
Yes.
You can remove that one.
Exactly.
And put a different one. If you want, you can test now to remove this one and put a different one.
Yeah, I'm doing it now. It's removed, and now I take the other one. Now I see. There was another one. There was the minutes of yesterday. Now I can have 2. Now I know why it didn't accept.
Okay. I can see 1 now.
So real the form and open. Again, it tells me I can't, but there is only 1. No, now I take the 1 away, and there is no other chance. Exactly. It's interesting, I took 1 away, but it's still here, and it's interesting. Now I try to take the next one. It's good to make all these tests.
Yeah, for sure.
Because we share the screen, you see what I see.
Yes.
So you see there is nothing here, but when I click here now and I'm uploading, you see there is 1. I should take it away now from here and then say like this, and now I can put the other one. But it tells me I can have 2, but it does not allow me. Now this is the second. This is a PowerPoint. I am very narrow to my router, and I have good internet, very good internet. I don't understand. It's very, very.
And do you have
slow.
the PDF of the second one as well?
I have also the PDF. Yes.
Yeah, I think that would be easier to use the PDFs for both, because it will be just quicker.
Yeah, and now it's there, but probably I will use the PDF. Yes.
Yes. So now it will
now
go.
I'm taking it away, and I take this also away, and then and then I put both PDF because probably the PDF is going, and pattern of skin inflammation, open.
And then we tested your finishing as well. Everything is working fine.
Fine, thank you.
You don't need to worry about that.
Now choose the second. And this psoriasiform, and it's small, and I open it. Okay, now I have both there.
I can only see one.
Yes, this is charging the second, but it's coming.
Okay, fantastic. Yeah, because that's the first one.
Yes. I let the second be charged, and then I retry to go through the slides quickly, but not all. So both are now there, and this is now the first, and then
that's the first one. Yeah.
I say hello, and I show the slides. This is perfect. I just make it bigger to see if the quality is keeping fine. Yes.
It looks fine to me. Very high res images. Yeah.
It's not as PowerPoint. I mean, if you look here, there is like a little bit of flu. I understand that this is PDF, but I think it's enough because I'm not losing so much quality. I'm just going quick through. Okay. Now ask, and now I go to the second one. It went quite quickly. Okay, and then I make it bigger. And sorry, yes, it's correct. This is fine.
Then it's perfect. And then we're going to play the third presentation, and then we're going to go on a lunch break, and then it's all pre-recorded, pre-uploaded for you, so everything should go smooth. And when we start, we're also going to issue the YouTube link, so in case something doesn't work, people can go into YouTube like they did yesterday.
Yes. The only thing is, you know what, I try quickly something, because this presentation, it's the quality of the slides is definitely not what it should be. But the sum of both, when I put, so 28 plus 13 make 38, 43. No, it should go. I try to take away the psoriasiform and put the PowerPoint, because it is definitely another quality. So this was the second, and now.
Oh, you removed both of them. Okay.
No, it's very interesting, because you look, it's still here. And now he showed me the other way around in the order. So now I have to re-upload the first PDF. The problem is I don't read the name when I was canceling. It's too small. Now this is the PDF. I should only use as PDF because it's too large, the other. And now it's coming. And then I take this. I try. I let the other charge until the end before I click for the last one. We still have 15 minutes. Now, pattern of inflammation is there, and now I try this PowerPoint. Let's give him time. Okay, now it's here. Now, the first was okay. I rechecked because we re-uploaded, but I don't only recheck a couple of slides. Okay, now it's fine. I go back. No, but it's fine. It's fine. And it's starting from here. And now this is, sorry, as if I'm, you forced the second?
Yes.
Okay, now, perfect. Now it is like this. Yeah, it's interesting. It's somehow you see it's a little bit fluid, this image. Somehow also the PowerPoint is not. If you look in the upper part, but this at least now this is the PowerPoint. It's the best quality we can have, and we will use it.
Yeah.
And how can I go now to the psoriasis form back?
So you basically need. I will remove this for you, and then I put this one for you.
Okay, perfect. And then now we have to go back to the. I go back here in the second.
Don't worry, I'm already changing the slides for you to the beginning. That's
perfect.
it.
That's fine. For me, it's fine. I'm ready.
So, okay, so you're happy with it? Okay, perfect. So basically at exactly 9 a.m. the live stream will start. So we will play first picture for around 30 seconds, then second picture for the 30 seconds, and you show me heads up, and then I will put you in the stream.
Yes.
And when you see your face, you are live, so you're good to go.
Yeah. From 9 o'clock, 2 times the first and the second picture. So we will have like 1 minute less.
Exactly. Okay. Exactly. You will have 1 minute, and then you show me thumbs up, and then we put you on the screen.
Fantastic.
So we also wait for people to join. We just give them a couple of minutes.
Yeah.
And then you start. I think that's the best way.
Perfect.
Fantastic. Well, yeah. Good luck. And
thank you. See you in 10 minutes.
Yes, and also I'm on WhatsApp or something.
Thank you.
Thank you.
Good morning, everybody. Welcome to this Dermatopathology Essential this morning on a beautiful Saturday. Thank you that you take the time to be here. Dermatopathology Essential is a new Fortbildung desired from the SGDV, and we are doing this today for the 4th time. So we are beginning a cycle of 3 dermatopathology essentials. We did it the last 3 years, and we completed the whole dermatopathology spectrum. And today we have inflammatory diseases. After my 2 lectures, there will be Heather Dawson, and then Peter Heusermann, Andreas Volz, Beda Mühleisen, and Laurence Feldmayer filling the program. I say welcome also to the African dermatopathology interested in dermatopathology in general, African specialists. They are guests here. They are invited to this conference. The last 2 days we had the African Dermatopathology Conference, also online, and now they have the possibility to join this conference as well. So we begin now with patterns of inflammation, the first topic. As you know, the skin can show different patterns of inflammation. And as you probably also know, there are more than 3,000 diagnoses. And the way these 3,000 diagnoses are divided and distributed in the skin through shapes, different shapes and different distribution make this field very, very challenging and interesting. So there are 2 main ways to see inflammatory diagnosis. One is a pattern analysis from Ackermann, and you will have to check perivascular, superficial and deep, lichenoid, nodular, diffuse, interstitial, bullous, and so on. You have different ways to see the inflammation. And here you see in a schema from the book of Whedon, you see the perivascular, superficial and deep, the diffuse, the interstitial, and here the vacuolar interface with in addition the lichenoid pattern of a band-like inflammation, here more a perivascular inflammation. Here you have the nodular, the intraepidermal blister, the subepidermal blister, lobular paniculitis, septal paniculitis, and folliculitis. And then you have a way also described in Whedon's book, where you have again the lichenoid pattern, and then spongiotic, psoriasiform, neutrophil-rich, eosinophil-rich, granulomatous, and we will go through a couple of these patterns now. For you, the most important as a learning person, as a beginner in the dermatopathology, lichenoid dermatitis are the one underlined, and we will show some particular examples of the lichenoid dermatosis. Lichen planus, as example from this magnification, what is important is the band-like inflammation and the rete ridges that are quite elongated and are like a saw. And then you have a very similar pattern in the oral lichen planus with the oral mucosa instead of the skin. Again, the band-like inflammation. And of course, when you go in a bigger magnification, you see the apoptotic cells and you see better the vacuolization of the basal cells. The lichenoid keratosis is in fact very, very similar like lichen planus. It's a lichenoid inflamed seborrheic keratosis. In lichen sclerosus, you have classically, I just highlight what is, let's say, particularly present in this particular disease. We are now in the topic of the lichenoid diseases. So the interface dermatitis is present everywhere. And here you have, in addition, the sclerosis of the papillary dermis. And here in lichen nitidus, you have a classically 2-3 papilla large inflammation. And this inflammation is lymphohistiocytic with some larger histiocytes or giant cells. And in addition, you have the inflammation, which is lichenoid here. It's a classical pattern correlated to the clinic. It's very easy to recognize. And when you have a lichenoid disease, like this one, and in addition, because in lichen planus you have nothing in the deep, and in addition you have periacrine inflammation, it's a lichen striatus. In a classical allergic reaction, a toxic allergic reaction of the skin, so toxidermia, the dress, you will have eosinophils in addition to the lichenoid inflammation. In a fixed drug eruption, typically also the lichenoid inflammation, the eosinophils, and a lot of pigment incontinence that give you the color of the skin clinically. GVHD is a very, very discrete disease. You see only some vacuolated cells, but several apoptotic cells. And in the erythema multiforme is the characteristical pattern of ballooned and apoptotic keratinocyte in the basal zone with a little bit of inflammation. What is special in dermatomyositis? The atrophy of the epidermis and deposits of mucin, which make the dermis pale. Lupus and dermatomyositis may be very similar. Sometimes they differ. And in fact, in these two pictures, they are different. Here you see the atrophy of the epidermis in dermatomyositis, and here it's acanthotic, the epidermis. The pattern of inflammation in the dermis may be similar in the sense that this is very dense perivascular, like here, and you have the mucin in the dermis. When you have a little bit of lichenoid changes and you have erythrocyte extravasation, but no damage of the vessels and no vasculitis change, you may think of lichenoid purpura. And when you have similar, like in erythema multiforme, a big damage of the basal cell zone with a lot of vacuolization and a lot of apoptotic cells, all the red one here, with a superficial and deep perivascular inflammation, there is a pityriasis lichenoides to keep in mind. Lichenoid diseases, we did it. Now let's look at a couple of spongiotic diseases. And when you have spongiosis, you may have in addition eosinophils or neutrophils. Sometimes you may have spongiosis in the follicles or other spongiotic disease like the whole group of eczema. What is classical in spongiotic disease is this whitish coloration of the epidermis. That means that there is water in the keratinocyte and around the keratinocyte, between the keratinocytes. This water, when it goes out, it's like an exocerosis in stratum corneum, and this is the wet that you see clinically. And this is not only in eczema. You may have a similar spongiosis in bullous pemphigoid. You may have it in a drug reaction like AGEP, but in addition, then you will have the neutrophils that are in stratum corneum in a small abscess. Or in bullous pemphigoid, sometimes you don't have so much spongiosis and you have mostly the eosinophils going into the epidermis. Pityriasis rosea is a particular disease between spongiotic and lichenoid. You may see some vacuolization of the basal cell zone in addition to some spongiosis, and classically the stratum corneum has a small zone of parakeratosis. Classically, you also see a couple of erythrocytes extravasation. The next pattern we will see in the next lecture better. I go a little bit more quick here, is the psoriasiform dermatitis, of course, in psoriasis, in Bowen, in chronic eczema. And typically of psoriasis, the elongated, single elongated retroridges, only little fusioning between the two, and the capillary dilatation. Pityriasis rubra pilaris, you see, it's also acanthotic epidermis, but it's more fusioning. The stratum corneum is very thick, and you have an alternation horizontally and vertically of parakeratosis. It's something difficult to be really seen, but it's described in the books that it should be like this. And now look, psoriasis, as we saw, and now chronic eczema. You see there are a lot of spongiosis, more than in psoriasis. And look, the fusioning of the retroridges. You don't see so many retroridges single. And this is the classical difference, when is there difference between eczema and psoriasis. I mean, chronic eczema. Lichen simplex is very similar than psoriasis. Look, again, the single retroridges going down, but a big difference. No inflammation at all. No Monroe abscesses, no neutrophil in stratum corneum, no parakeratosis. Bowen disease is also an acanthotic epidermis. It depends from the situation, how acanthotic it is. But of course, in addition to the acanthosis, a lot of atypical keratinocytes, mitotic figures, which make the whole story different. And then you have neutrophil-rich dermatitis. So a dermatitis which is mostly based on these cells, and then you have impetigo, mycosis, subcorneal pustular dermatosis, of course the AGEP, psoriasis, the pustular and the non-pustular one, IgA pemphigus, infectious panniculitis. So these are the most important. And look, AGEP, we already saw one image, and here we see another one. Maybe this is the image a little bit before. we have a very, very small pustule in the substratum corneum zone, and a little bit of spongiosis, a little bit of ballooning degeneration of the basal cells, some apoptotic cells, classically of a drug reaction. They are not obligatory, but when we see them, it's easier to do the diagnosis, and a little bit of parakeratosis. Of course, here you do a pus coloration and you don't find a fungal element. In pustular psoriasis, the pustule may be small or large. Here is a very large pustule, subcorneal, making also a little bit of necrosis of the epidermis. And sometimes you are able to see the other psoriasiform characteristic that we already spoke before, sometimes not so easy. I have to say, in palmar and plantar skin, it's not so easy to see again the pattern of psoriasiform dermatitis and to make a good distinction from eczema. We will see in the next lecture. Sweat. What is classical in sweat? You have a lot of edema under the epidermis, and this is really something that you should think first of all of sweat and then maybe perniones. There are a couple of other differential diagnoses. But then in the dermis, it's full of neutrophils and you have an interstitial neutrophilic dermatitis, and this is how you make the diagnosis of this disease. IgA pemphigus, so in principle you have an acantholysis like in the whole pemphigus group, but in addition you have an inflammation based on neutrophils, and this helps to make the difference between the classical pemphigus or other acantholytic diseases. Psoriasis vulgaris, just a picture on this Monroe abscess. We are speaking about neutrophils in the dermatitis. And in Behçet disease, of course, Behçet is classically a neutrophilic disease, of course, but not only. Behçet is a systemic disease, and one of the main finding in Behçet is the vasculitis. So look for neutrophils, you will see them, and look for the vasculitis because it's important to make the diagnosis. Other diagnoses rich in neutrophils that you should know are erysipelas and cellulitis, but these are a little quantity of neutrophils, I have to say, and then of course some infection like atypical mycobacteria and Pyoderma gangrenosum or the leukocytoclastic vasculitis. In vasculitis, you may see, look, this is a vessel, it's partially destroyed. Here you still have an endothelium. On this side, you don't see no more the endothelia, and this is fibrin. And this other vessel here is destroyed, and you have a little bit of neutrophils around and leukocytoclasia. Linear EGA dermatosis and During. I discussed these two at the same moment because they are very, very similar from the histological point of view. You have subepidermal abscesses. So under the epidermis, collection of neutrophils. And when you are lucky, you see also the blister subepidermal. And these two diseases are very similar. And then in the direct immunofluorescence, you will see linear EGA deposits in this disease and granular IgA deposits in During disease. And of course, the clinical picture is a little bit different. The age of the patient is different. Maybe there is association with the drug in linear EGA dermatosis and with gluten problems with the Durings. I don't go too much into details, but you see histology may be very similar, and then the rest of the information is helping you to understand better the disease. Neutrophilic urticaria is of course an urticaria clinically, but histologically you don't see the few cells typical of urticaria and the clear edema typical of urticaria, or maybe you may see it, but in addition you see a lot of neutrophils. And in the classical urticaria, you may see neutrophils in the vessels, and here they are also around interstitial, and it gives you the chance to make this diagnosis together with a clinical pathological correlation. In some of these cases, you may also see a vasculitis. And then you have a neutrophilic urticaria with vasculitis, which is possible. Cicatricial pemphigoid may differ histologically from the classical bullous pemphigoid by the presence of more neutrophils. In bullous pemphigoid, these cells may be seen, but they are not typical at all. Mostly you see eosinophils. But when you see more scarring and more neutrophils and the subepidermal blister, maybe in addition to the clinical picture, knowing head and neck changes or mucosal changes, then you can do the diagnosis of the cicatricial pemphigoid. Here, just summing up what we already say, what could be neutrophilic dermatitis. And now the eosinophilic dermatitis. Of course, one important disease, it's bullous pemphigoid or pemphigoid gestationis, which is a very, very similar disease in different setting. urticaria, parasites. And look, in bullous pemphigoid, when you are lucky, when you see blisters, you may have this classical subepidermal blister with a little bit of inflammation. It must not be a lot. It could be more, but it's classically like this. And you see classically eosinophils around the vessels and sometimes in the dermoepidermal zone or going into the epidermis. We saw it in a picture a couple of minutes before. Pemphigoid gestationis is very similar in a different age group or in a different pathophysiological group. These are pregnant women, and we don't know exactly why these two group of people, the older patient and the pregnant, may have a very, very similar disease. Now, what you should know is that when you have a lot of eosinophils in the dermis of any origin, you may see flame figures. So don't think that flame figures are specific for well disease. Of course, you will see them because you have, of course, a lot of eosinophils. And in well disease, you don't have a couple of eosinophils perivascular like it could be in bullous pemphigoid or like it could be in the drug reaction, but you have classically a lot of eosinophils, and degranulation of eosinophils in the dermis may lead to the picture of the flame figure like you see here. So flame figure is equal a lot of eosinophils in the dermis because of any reason. So also in a parasite, you may see flame figures or in an arthropod bite. And here, in fact, you see scabies. In this picture, there is no flame figure. There are just the eosinophils. And when you see a lot of eosinophils in the dermis, you should always think of a parasitic infection, and then you go to the stratum corneum and you look for eggs or for scabious mites, or you speak with the patient and you try to understand what is going on. And in urticaria, as I said, a very, very discrete inflammation with a little bit of edema. So you don't see a lot, nothing in the epidermis, nothing in stratum corneum. You may see some neutrophils in the vessels and a couple of eosinophils around the vessels. Here is summing up what we already said. There is the eosinophilic fasciitis as an additional diagnosis. And AJEP, we found the AJEP in the lichenoid diseases because it's lichenoid. We found the AJEP in the neutrophil diseases because you have neutrophils in stratum corneum as a small pustule. And now you have it AJEP again also in the eosinophil diseases because you may see eosinophils because it's a drug reaction. So remember that this pattern may have overlapping connections. In the eosinophilic folliculitis, of course, this is a folliculitis, but it's a special one. You may have it in patient from Asia or in patient with HIV, and then you have a lot of eosinophils centered in or around the follicle. With folliculitis changes in addition. Granulomatous dermatitis. Sarcoidosis of course should be mentioned, but then also granuloma annulare, necrobiosis lipoidica, the classical infection like tuberculosis, leprosy, and so on. What I say, when you see a granuloma, it's turning somehow the history easy because you don't have a lot of granulomatous disease that we should think in the skin, and look at this list here, it's not very long. And of course, the group of the infectious granulomatous diseases is long. You can do microbiological analysis to understand better the situation. What is classical in sarcoidosis? You have, of course, the granulomas, and the granulomas are mostly naked. What means naked? That means that you see mostly only histiocytes and not a lot of lymphocytes. The lymphocytes are the blue cells, like here. This is a zone with lymphocytes, and this is only histiocytes. So a lot of histiocytes making granuloma without a lot of lymphocytes around. No necrosis, classically, and no presence of amounts of plasma cells. So going away from the idea of an infection, classically. If you do Zil-Nielsen, you don't find nothing, and you have to make the clinical pathological correlation to make the diagnosis. Granuloma annulare is a zone of degenerated collagen. You can call it also necrobiosis, but the generation of collagen is probably better. And around this zone, you have a palisade of giant cells. If you stain for mucin in the middle, it could or should be positive. And sometimes you have a debris of some neutrophils also in the middle of the granuloma annulare. Necrobiosis lipoidica is very, very similar as granuloma annulare. Granuloma annulare is mostly an isolated field somewhere in the dermis, or a couple of fields somewhere in the dermis, the same changes spread in the whole dermis like a lasagne. So a little bit of the granuloma and then normal dermis and then granuloma and then normal dermis is necrobiosis lipoidica, but with a couple of differences. Usually no mucin if you stain for mucin in the center of the granulomas, and usually you see some plasma cells that you don't see in granuloma annulare. So these are the differences. And of course, the clinical picture is different. So remember, clinical pathological correlation when you have this type of granuloma is mandatory. I go on the right, granulomatous rosacea. You have a granuloma around the follicle. So it could be a granulomatous folliculitis or a granulomatous rosacea. And the granulomas are frequently sarcoidal from the type. So it remembers a sarcoidosis. It's when this disease, when you have this histology and you are from the head and neck, then again, you need the clinical pathological correlation, because a folliculitis and the rosacea may be very similar histologically when it is granulomatous, but clinically, you may have a little bit of differences. And here in the middle, you have, after a suture of a surgeon, a granuloma in a re-excision of a tumor. So this is not important. Now we just see the suture, which is here in green, and around the suture points, you will have these giant cells that try to absorb this foreign body. And as I said, all the infection diseases may also be granulomatous, of course. And here I have a couple of examples. We have increasing number of leishmania. I have to say, maybe every year we see 3 to 5 cases, and these are cases from Europe, not imported from tropical countries. And we have here a granulomatous disease, mostly histiocytic. And if you go with the Giemsa coloration here, you see all these dots here that are the leishmania bodies. On the right side, you see again a lot of histiocytes. Why histiocytes? Because it's pink here. When it is full of lymphocytes, it would be much more blue. So the zone which is more blue, like here, is lymphocytes, and the zone which is more pink, like here, is histiocytes. So lympho, histio. And when you have histiocytes, foamy histiocyte, you should make the Thiel-Nielsen coloration, and then you will see the small bacteria, in this case of leprosy, that I saw in Africa. Histoplasmosis. Here you see these small dots into the cells. You see it here, here, here. So these are foamy histiocytes again, with a phagocytosis of a material. You see the small dots, these 2 here. And this is the case of histoplasmosis, another case that we saw in Africa several years ago. And here you have a granulomatous disease, but in addition, a lot of plasma cells, and in addition, in this case, also a lichenoid inflammation. When you put together lichenoid inflammation, granulomatous inflammation, and plasma cells, you should think of syphilis, and then we did the coloration and we found the treponema. Vasculitis, vasculopathy. So vasculitis is an inflammation of the vessels. Vasculopathy, it's a problem of communication, let's say, to make it simple, between the coagulation parameters and the wall of the vessel. And you may see a thrombus, or you may see an hemorrhage, but you don't see an inflammation. And antiphospholipid antibody syndrome is a classical vasculopathy, and SNEDOM also. And then, of course, the classical vasculitis, urticaria vasculitis, or vasculitis in cryoglobulinemia. And here, as already said before, when you have a vasculitis, you have an inflammation of the vessel, you have the vessel wall which is damaged, and you have a leukocytoclasia, and you have hemorrhages around the vessel. And this is a disrupted vessel. And the same is here. Here you have it in cryoglobulinemia. Histologically, you cannot make the difference. You should make other analyses to find it. And again, the vasculitis, which is very, very important in Behçet. In addition, in this last patient here, you have an inflammation which is full of neutrophils, not only around the vessel, but in the rest of the dermis. And so you may think you see, yes, a vasculitis, but you see it in a context of something more, and this is a neutrophilic disease, in this case, Behçet disease. We are finishing this first half hour with the bullous dermatitis. Bullous dermatitis can be of any level in the skin, so in stratum corneum, under the stratum corneum, in the epidermis, or in the upper epidermis, in the lower epidermis, or subepidermal. And in addition to these levels, where you may see the bullous dermatitis, you have other cells participating to the inflammation. So the presence of neutrophils or the presence of eosinophils or of plasma cell may lead you in the differential diagnosis. And then, of course, there are some infections also making bullous dermatitis. Let's save a couple of examples. IgA pemphigus. So you have the acantholysis with swimming cells, acantholytic swimming cells into the blister, in addition to neutrophils, a lot of neutrophils. A picture like this you may see like in an herpetic disease, but classically in herpetic disease you may see giant cells or eosinophilic giant cells due to the viral effect. Sometimes it's not easy to see the difference, and then you have to make a coloration immunohistochemical or to do other analysis. I go to the pemphigus here. In the lower part, this is the tomb-like pattern. So in pemphigus, you have a acantholysis, which is basal in the epidermis, and what remains is just the basal zone, and the roof of the blister goes away. It's not obligatory, but this is a classical pattern. I go on the other side, on the lower part, just the opposite in the epidermis. In pemphigus foliaceus, the other pemphigus, you have a blister which is classically in the upper part of the epidermis, and look, it's just subcorneal. So pemphigus vulgaris, typically basal blister. Pemphigus foliaceus, typically upper part of the epidermis. And it shows you where the desmoglein are. In pemphigus foliaceus, you have the blister here because there are antibodies against desmoglein 1, which are more in the upper part of the epidermis in the skin. And in pemphigus vulgaris, you have the blister in the lower part because you have the antibodies against desmoglein 3, which are more in the lower part of the epidermis in the skin. And here, pemphigus vegetans, that you may see abscesses of eosinophils in the epidermis, and you should make serial steps when you have this picture to find the acantholytic zone. On that picture here, you don't see a lot the acantholysis, but in the next slides, we should see it. And Grover disease is something particular. It's an acantholytic disease associated with an inflammation with some eosinophils, with a particular picture of these crusty lesions, pointy on the chest. Here are the differential diagnosis of bullous dermatitis. Of course, you may have bullae also in the contact dermatitis or in the fixed drug eruption, which is classically maybe not bullous, but it can turn into a bulla, or like in arthropod bites. A couple of last pictures. Bullous pemphigoid, subepidermal blister, eosinophils around the vessels, eosinophils in the blister, and sometimes eosinophils in the junction zone or in the epidermis. Pemphigoid gestationis, very similar picture. I cannot make more comments. Lichen sclerosus is not a classical blistering disease, but it may be blistering because of the lichenoid changes that are affecting the dermoepidermal zone, and sometimes there is an edema in that zone, and then you have a blister. There are two different reasons to have a blister. Here there is no edema, but due to the lichenoid changes, you have a blister subepithelial, and the sclerosis here, which is classical of this disease. Fixed drug eruption, you don't have the blister in this picture, but you have the other classical characteristic: lichenoid changes, pigment incontinence, eosinophils in the inflammation, apoptotic cells. And erythema multiforme, again here, not a blister on that picture, but it can be blistering due to the lichenoid change, which are quite severe sometimes. Here, a list of what we spoke now, and we go with a couple of slides. The dermatitis herpetiformis during and the linear IgA dermatosis that we already saw in the neutrophils-rich diseases. We found again here in the blistering disease because they have both what is the classical picture, a subepidermal blister and a lot of neutrophils under the epidermis. Both histology may be very similar. The direct immunofluorescence is different. Linear IgA deposits here, granular IgA deposits here. In a bullous drug eruption, you see all characteristic of the drug eruption: superficial and deep inflammation, eosinophils somewhere, lichenoid changes, and you may see a blister. And in sweet disease, it's not classically a blister. You have an edema of the subepidermal zone, and this edema can turn into a blister. And it's a neutrophilic disease. So we finish with this pattern of inflammation, and I'm preparing now the second. Okay, now we go for psoriasiform dermatitis. We concentrate now on the pattern of psoriasiform. Classically, we see the psoriasiform pattern in psoriasis, pityriasis rubra pilaris, chronic eczema, lichen simplex, prurigo, and insufficiency dermatosis. These are the main diagnoses where we see this characteristic, and we will discuss them. In addition, you may see a psoriasiform dermatosis also in these other diseases. So mycosis fungoides can be psoriasiform, some erythroderma, the Harald patch of pityriasis rosea, and so on. But we will focus on the first group. We are not now in a lecture hall. I would ask you, and I would like to see your answer, what is the common denominator of all these pictures here? Look at the pictures a couple of moments. So we have erythroderma, we have an abscess in the finger, we have ragates on the hands, we have sharp circumscribed plaque on the buttock zone, we have a plaque on the body, we have a hyperkeratotic or non-keratotic plaque, we have guttata lesion, pustules, and balanitis. All of these patients have psoriasis. With this picture, I'd like to show you how many faces one disease can have. And here we just have different phases of different type of lesion. We don't put the different phases of the chronology because you may have early lesions and late lesion of all of these pictures. So you understand how different the clinical picture possibilities are. And in the same way, you understand that the histology of that different clinical pictures may also be different. And so it makes the diagnosis in some case of only one diagnosis. You are speaking of psoriasis, and the same you can turn the discussion in other diseases. It may be difficult. Now, what is classical in psoriasiform dermatitis is the presence of an epidermal hyperplasia with elongation of red ridges in a single zone. And this, it's coming because of a high mitotic activity of the epidermis. And there is an exception who leads to a similar pattern, but it's not due to a high mitotic activity due to like an inflammation. It's lichen simplex. If I scratch my skin day after day during several months, I get a similar pattern, but it's not due to an inflammation. Or in Bowen disease, because it's due to pure mitotic changes, because this is a tumor which is growing. So let's look at psoriasis. You see here that there are variants. You know the variants. We already saw some pictures before, and now you see a list. And what we can say as general remark in psoriasis, the exanthematic types of psoriasis are mostly in children, and the chronic type are mostly in adults. In hand and feet, I already said it half an hour ago, the differentiation from eczema is very difficult, sometimes impossible. And you should remember that there is a life of lesion, so characteristic may change during the life of the lesions. Take a look of this publication here, and take a look to this picture in the lower part right. You see there are a lot of small dots. These small dots are first very regular placed. The distance from each other is very regular, and the size of the dots is very, very regular. So here we have picture of psoriasis and dermoscopy of psoriasis. And why we have these small dots, I will go in another picture to show it better, but I remain on these slides. The capillary dilatation on this regularly elongated between the regularly elongated ridges in psoriasis are the reason because you see the red dots here. So when you go with the dermatoscope, you have more chances sometimes to distinguish eczema from psoriasis with your dermatoscope. What is the difference from eczema? In eczema, you have different size of the dots, first of all, and there is irregular placed of the dots. Look, this could be an eczema. So maybe a long dots and then a small dots and or smaller dots and irregularly placed. And in psoriasis is more regular. So the early histology in psoriasis, you have classically this pattern here, capillary dilatation and congestion erythrocytes in the papillary edema. The acanthosis is not yet a lot here, and then a little bit of spongiosis. So remember, the classical eczema pattern, the spongiosis, may be seen in early psoriasis. And then you have other couple of examples that you may see. In the late psoriasis, you have the confluent parakeratosis. So the changes are reaching the stratum corneum after a month. Munro abscess, stratum corneum. Cogoi abscess, neutrophils in the epidermis. Hypogranulosis due to the turnover of the epidermis. Psoriasiform acanthosis with single elongated reteriges, we already spoke it. Dilated capillary, so you have the full picture. And at the end, also the thin suprapapillary epidermis that when you take away the crust with your finger, it's pointedly bleeding. And now we see a couple of histological pictures. Look, regularly elongated reteriges with this dilatation of capillaries here. And you see, not every disease read the book. So in this zone of the same patient, so here, there is more dysregularity and here is more irregular. When you are unlucky in the same patient, you do a biopsy of this zone and then it's more likely an eczema. You see how it can change within 2 millimeters. Here you see this capillary dilatation, which are responsible for the picture I show you in the dermoscopy. You see some spongiosis, which is possible. You see that the suprapapillary plate contains only 3 or 4 keratinocytes, and you understand why it is bleeding if you take away this crust here, because it can damage the upper epidermis. And in the superficial epidermis, you may see some neutrophils in the inflammation. Similar change with Munro abscesses you may see in a nail of a psoriatic patient. Of course, the pus coloration should be negative and show no fungal elements. In the pustular psoriasis, you have to know that you may see some few eosinophils. So the clue you could theoretically think it make the difference from an eczema is not present, so it's difficult to make in a palmoplantar ragadiform pustular dermatitis to be sure if it is eczema or psoriasis with a biopsy. When you are lucky, there are classically psoriasiform changes and not eczematous changes, and then you can make the difference. But in more than 50% of the cases, you are not lucky and the changes are not specific. Here you see the pustule, and you see, of course, some single reteriges elongated, but also a fusion of reteriges. So it's not so easy to be sure eczema or psoriasis. And as you may see, some eosinophils is getting even more difficult. There is a publication of a couple of years ago, almost 10 now, that shows you what are, and this is when you see p-value less than 0.001 are the statistically relevant points. And you will see that the eosinophils are not statistically important to make the difference. Most important is the continuous parakeratosis for the psoriasis, the presence of a lot of spongiosis for the eczema. And these are the most important points that you see. And you see the full thickness spongiosis is here for eczema, and the tortuous capillaries in the dermis for psoriasis, and then the diffuse parakeratosis for psoriasis. So in erythrodermic psoriasis, the particular type of psoriasis, it's similar like the early psoriasis. So you may have also spongiosis, and you see a lot of this capillary dilatation and less the acanthosis of the epidermis. Small slides, short slides, DD erythroderma, 4 most common cause. Think always to drug, eczema, psoriasis, and lymphoma. These are the main cause of erythroderma, and then you have other, but you should first of all exclude or diagnose one of these 4. So now, in early lesion of psoriasis and in pustular psoriasis, there is not this psoriasiform epidermal hyperplasia. Spongiosis may be seen early and in erythrodermic psoriasis, and eosinophils may be seen in the palmoplantar psoriasis and may be seen mostly when spongiosis is also present. We change topic, pityriasis rubra pilaris. You know there is an adult type and the juvenile type, and there are variants. I don't go into too much details. What is the most important thing? One point is the histological changes are most marked when erythema is greatest and less impressive in follicular papules. A lot of people, because pityriasis rubra pilaris is somehow follicular, or it goes around this zone, you make the biopsy on this classical follicular zone. Please do the biopsy in erythematous flat zone, not around the follicles. You may see a better histology. What is most important to recognize in the histology is you have an acanthosis. Yes, similar like psoriasis, but what is different? It's not so regular, it's more irregular. A little bit more in a zone and then less in another one, a lot of fusion of the rete-ridges. And this is important. And then this alternation of parakeratosis horizontally and vertically of the stratum corneum. Hyperkeratosis, different from hypokeratosis in psoriasis. And the rete-ridges are broad, not so thin, not like elephant feet, but very, very broad. And this is another big important difference. And these are the main differences. And you don't see neutrophils in stratum corneum, so this is another point that helps you to make the difference from psoriasis. And I have only a few pictures of pityriasis rubra pilaris. Here you may appreciate in this lower picture here the alternating between a line of parakeratosis and then nothing, and then again parakeratosis, and then nothing, and then again parakeratosis. And these lines are horizontal, and then you may find also some lines vertical. I see you may, because it's not so easy to show it. Look, the epidermis is not like in psoriasis, it's acanthotic, yes, but irregular. It could be similar like eczema, the way of acanthosis. But the parakeratosis is different, and you should not have classical eosinophils. So that are the differences. We go into the eczema. And here you see the dermoscopy of the eczema, where you have the different dilatation of the vessels, which is not so regular like in psoriasis, and the size of the vessel is not so the same. You have an acanthosis, of course. We are here in the group of the psoriasiform dermatitis. And in addition to this acanthosis, which is mostly irregular and more fusioning between the rete-ridges, you may see some spongiotic changes. And of course, some eosinophils then in the dermis. Look, on that zone here, you may think of psoriasis, of course. You have the single rete-ridges. And then you have here spongiosis and broad rete-ridges, fusioning of rete-ridges. And you see here spongiosis, parakeratosis, exocerosis above spongiosis. You may find eosinophils in the epidermis. Look, the rete-ridges are elongated but broad, very broad elongated rete-ridges, spongiosis, eosinophils in the infiltration, not a classical line of parakeratosis, not the Munro abscesses. Sometimes you may see some neutrophils in stratum corneum. This is the so-called impetiginization. We go to the next topic, lichen simplex, which is theoretically just a consequence of chronic scratching during weeks or months. This is, of course, a theory. In practical points, you may have it also as a chronic scratching on an inflammatory disease. So you have two ways how you come to a lichen simplex. The non-inflammatory is easier to diagnose because you don't see inflammation and you see the acanthotic change, and then you can go for it. When you see an inflammatory changes, you may think that there is an inflammation in background who leads to the lichen simplex. There are synonyms of this lichen simplex. You see it here. What is the histology? Irregular acanthosis with fusion of the rete-ridges, broad dermal papillae. You may have a compact hyperkeratosis with hypergranulosis under it, which is very important as a sign that it's an acanthotic epidermis. And in the dermis, you may have a papillary fibrosis, again, due to the mechanical stress. Sometimes you may see erosion, excoriation, or ulceration due to the scratching. Here you don't have epidermal ulceration or erosion. You just have the lichen simplex with a lot of hyperkeratosis. If you see this kind of parakeratosis, you may think of acral skin. The acral palmoplantar is exactly like this. But when you look and you see the hairs, you see it's not possible. It cannot be acral skin. And Bernie Ackerman described this as a hairy palm sign. That means you see something like palmar, but you see the hairs, so it's not palmar. And it's classically constellation that you see in lichen simplex. And in this case, it's not an inflammatory lichen simplex. It's mostly due to just for scratching. If this patient would have an eczema, and due to the eczema, it would develop a lichen simplex, then you would have eosinophils and the perivascular inflammation and maybe the spongiosis in addition. Hyperkeratosis and hypergranulosis. And you remember, here you have more regular reteriges and here you have more irregular reteriges. Both are possible. And the fibrosis of the dermis, look here, it's easy to recognize due to the scratching. And again here, like palmar skin, but with hairs. Prurigo is nothing else than the same concept in an exaggerated way. So as the histology is very similar as lichen simplex, but you have even more acanthosis. You may have pseudocarcinomatous hyperplasia, sometimes because there is a crater, so an exulceration, as I said before. You may see inflammation, but not because there is an inflammation at the beginning, but because there is an inflammation reactive to the ulceration of the skin. Look here. At first glance, one could also think at squamous cell carcinoma. And this, in fact, is a differential diagnosis that you should consider and which is not always easy to rule out because you have a lot of epidermal structures acanthotic and going into the dermis. Sometimes it looks like it would be infiltrating. The clue is to look for differentiation of this epithelium, which is well differentiated usually. You don't see so many mitosis, but still some you will see because it is proliferating. I mean, this acanthosis has to come from somewhere, so the mitosis can be seen, and you don't see atypia of the keratinocytes. But I have to say, in the last 20 years, I saw a couple of cases where it was almost impossible to be sure, is it neoplastic or reactive? And the clinical pathological correlation and the rebiopsy or a biopsy of a similar zone in another place of that patient could be helpful. Here you see an excoriated zone with exocerosis, and you see like the wound consequences here in the lower part, like the beginning of a granular tissue. And here is a scar under this scratched zone with the classical hyperkeratosis and acanthotic epidermis psoriasiform pattern. Here you see a little bit of scarry changes with verticalized vessels and horizontal lining of the collagen in a scratched zone after an ulceration. And here you see the lateral zone where there is no ulceration, but just a skin similar of palmoplantar, but it's not palmoplantar. And then, before we finish, there is a group of deficiency dermatosis. So the necrolytic migratory erythema, so the glucagonoma or enteropathic acrodermatitis or pellagra. So when some vitamins or zinc are missing or in this tumor, the glucagonoma, you may have the same identical histology. The clue is you have a psoriasiform epidermal hyperplasia. That means you have this acanthosis again. You may have an hyperkeratosis, similar like the one you see in psoriasis or in lichen planus, in lichen simplex. In addition, and this is very important, you see pale ballooned superficial epidermal cells. So very, very pale. It's something rare. I would say we see it maybe 1 or 2 per year, and it's not always easy to let's say to make the difference with an artifact, because sometimes keratinocytes are pale stained because of a laboratory. Let's say I cannot speak about a mistake because something happening in the laboratory or a thin cut. You may see some neutrophils and some necrotic keratinocytes. I don't have a known picture here where I'm working now, so I cannot show you for sure my personal case. This is from the McKee book, and you see the ballooning pale cells in these cases here. And similar picture I've seen in other books. This is the most important message that I can show you about this Karenzi dermatosis. So for today, I'm finished. We did the psoriasiform dermatosis and the inflammatory pattern. And soon you can continue with the Heather Dawson with AI, artificial intelligence in pathology. Thank you for listening and enjoy the day.
Good morning, everybody, and thank you very much for the invitation to speak a little bit about AI and pathology today. So in comparison with the other topics discussed here, this is a little bit different. We're going to go over some concepts and some challenges that AI poses today, and also some examples on how AI is being used. So AI could be something that everybody talks about. Nobody really knows how to do. Everyone thinks everybody else is doing it, so everybody says they are doing it. And this has actually been likened to teenage sex, if you haven't heard it before. And as we all know, teenage sex can go very, very wrong. So let's set the record straight. So what is artificial intelligence? This is when a computer mimics human intelligence to perform a given task. So in our field, that could be a medical diagnosis. Machine learning is a subset of AI that learns to perform given tasks from data and improves with the experiences. And deep learning is something we hear very much about, and this is a subset of machine learning that uses large neural networks and big data to better solve complex problems. And as mentioned, deep learning is a form of machine learning. So say you want to teach an algorithm how to recognize cars. In traditional machine learning, you would sit down with a model and tell it what you think is helpful to recognize cars. So for instance, a steering wheel. And then that would go through a filter or multiple filters, and hopefully learn over time what is a car and not a car. And in deep learning, this step of feature extraction is left up to the classification system. So, and this is actually called a convoluted neural network. And it means that you give the model lots of different images of cars and not cars, and you tell it, you go figure this one out for yourself. So then it would ideally figure out which ones are cars and not cars. And there are some instances where it is more useful to use conventional machine learning, and some where you would rely more on deep learning. And deep learning traditionally needs lots more data. And this convoluted network and the CNNs are actually also inspired by the human brain. And speaking of the human brain, all of us certainly here, and anybody on the street, and even my 3-year-old daughter, can very easily recognize which one here is a blueberry muffin and which one is a chihuahua. And even though, for instance, my 3-year-old daughter probably hasn't seen very many chihuahuas, and hopefully hasn't eaten a lot of blueberry muffins in her lifetime, she has encountered so many similar images that she is very much able to tell the difference. And certainly nobody has sat down and told her which one is which. And this is kind of like how CNNs work. But since we don't really know what is going on in a CNN, they have been also called black boxes. And there are some topics here, or some terms here that are important. For instance, explainability. This is the knowledge of what a parameter represents to a model and its importance. So for instance, in an algorithm recognizing tumor cells, if you know that nuclear size constitutes 20%, chromatin density 40%, and nuclear contour 40% of the recognition of a tumor cell, this is explainable. Transparent models mean that humans can at least partially understand the decision-making process behind a model. And deep learning techniques are often black boxes and lack a certain extent of explainability and transparency, but they can still be extremely robust. This has some disadvantages. For instance, if it comes to your next favorite movie on Netflix and how that could be predicted, that's okay. But when it comes to a medical diagnosis, the stakes are much higher. So black boxes can lead to a lack of acceptance in the medical community. And for instance, when it comes to approval issues. It can also be hard for researchers to learn from a black box model because you're not quite sure what is going on. And also it can be difficult to identify bias. And what can we mean by bias? This is a very well-known bias, ethnicity bias, and this is basically facial recognition. And this can work very well if you happen to be a white male. But if you are an American Indian woman, then facial recognition algorithms may not work that well for you. And this is simply because the data that the algorithm is given to be trained and validated and maybe even tested on does not include nuances that would lead to the inclusion of recognition of all ethnicities. So obviously from an ethical standpoint, this can be very problematic. And this is why efforts have been made to make or to establish guidelines on minimum information about clinical artificial intelligence modeling. And this is the MyClaim checklist. And the goals of this checklist is to enable a direct assessment of clinical impact, including fairness and bias, and also to allow rapid replication of a technical design process of any legitimate clinical AI study. And one of the elements of this MyClaim checklist is reproducibility. And in an ideal world, all codes of all algorithms would be completely transparent and shared with everybody. But in our world, many codes and products are owned by companies and they are not quite as interested in sharing this code. So the medical community needs to be aware or needs to establish what is acceptable in terms of reproducibility for a product that is going to be used in the clinic. There are some current technical challenges in AI and in pathology. Certainly the largest challenge at the moment is a lack of generalizability. So you could have an algorithm and publish that algorithm and say it works 100%, but that is on the data it was trained on. Put it on or run it on other sources and it might not work as well. So training data needs to contain a certain amount of variation. And one strategy here has been called data augmentation. So that's when you take your training data and you modify it a little bit to make it look different. So this could be modifying the hues on an H&E slide. Another problem is that a model will only recognize what it was trained to do. Say you have a lymph node detection algorithm and you have a lymph node and it has lymphoma, and that cannot be missed. It is impossible right now to train an algorithm to recognize any other, every sort of disease, but what can be done is that it can present an unusual pattern and say, hey, I've looked at so many lymph nodes and I haven't come across this yet. This is something I don't know. Please check. So the My Claim checklist also describes components of an ideal clinical AI study. So at the beginning, obviously the clinical question must be clear, and also what benchmark must be met. So how should the algorithm perform in comparison to a gold standard? So depending on how it should be used, this doesn't necessarily need to meet or exceed the gold standard, but this has to be clear. And also a very, very important aspect is the data that is used to train, validate, and test an algorithm. This means special care has to be taken to avoid overfitting. So this is a problem with any type of prediction model. You need to have the data in a way that it can be applied to other data outside the algorithm, and also information leakage is a problem. So that would mean that your test data contains the same information as, or the same patients, for instance, as your training and validation data. So that would mean that the test data is basically already knows the answer. It's kind of like cheating. Information has to be provided on how well the algorithm is performing. And there are ways on how to explain even complex CNNs. And also information needs to be given on how this algorithm can be replicated. Another problem, especially when it comes to pathology images, is annotation work. And so this is a picture of colorectal cancer, and you can see it's very busy. There are lots and lots of different cells and different cell types. And say you were to establish an algorithm for tumor cell detection, and you needed to annotate each and every tumor cell in this image. That is very, very tedious work, and I can tell you that from my own personal experience. So this goes into the area of supervision in machine learning. Supervised machine learning relies on very, very extensively annotated data by a clinical expert, so in this case a pathologist, to establish a ground truth to train algorithms. And ground truth is a very, very strong concept, because it means the truth. And everything in pathology is prone to a certain extent of inter-observer variability. So say my ground truth may not necessarily correspond to another pathologist's ground truth 100% of the time. So that is also introducing a certain extent of bias to an algorithm. So are we training an algorithm to be essentially like me? Also, so these are some reasons why efforts have been made to establish weakly supervised machine learning techniques. So these use only sparse annotations, and the annotations, or this could also be information about a slide. Say this slide contains cancer or no cancer, and it uses different or more advanced learning strategies that can approach the performance of fully supervised systems. So for example, a self-supervised learning technique teaches itself by looking for similar patterns in unlabeled data. So this is an example of this self-supervised approach, a model or basically an algorithm that was created by our own computational pathology group. So this is a tissue segmentation model for colorectal cancer. So it tells you which cells are tumor cells, stromal cells, debris, lymphocytes, et cetera, et cetera. And it performs just about as well as a highly supervised model. So let's go more into pathology itself. Now, there it has been said that pathology has undergone 3 major revolutions. The first revolution was the introduction of immunohistochemistry. So that made it possible to detect certain antigens in the tissue by using an antibody and visualizing them. Then the second revolution in pathology has been said to be next generation sequencing. So you use a technique that uses large panels to detect relevant mutations all at once. And the third revolution in pathology is digital pathology and computational pathology. So this basically started with the clearance for digital diagnosis by the FDA in 2017. And the first algorithm to receive FDA approval for clinical use was for cancer detection in prostate cancer not too long ago in September 2021, about a year ago, by a company named Page. And I really like this image because it shows you the worldwide distribution of pathologists. This is a poster that was presented at USCAP pathology conference early on this year. And it shows us that even in the land of abundance in Switzerland, there is a relative shortage of pathology. And it's not like we have less specimens. The number of specimens we receive is also increasing, as is the parameters that we have to report, especially in cancer. You can't say melanoma fully excised anymore. There's a lot more that goes into the pathology report nowadays. So we have an increasing workload with a shortage of pathologists. So here's where we hope that AI can help us. There are several areas of applications in computational pathology. So first would be to address a fundamental question, such as object detection. This would be identifying mitoses or counting intratumoral lymphocytes. That can be very, very helpful because these are quite tedious activities. And also immunohistochemistry quantification, such as Ki67 or PD-L1. And then there are basic tasks that can automate pathologists' capabilities. So this involves some extent of interpretation for tumor detection, tumor subtyping, or tumor grading. And these 2 areas are basically where AI in pathology is today. And then there are also things that AI can do that a pathologist cannot do. For instance, predict genetic alterations, survival prediction, and response prediction. And there are some very promising studies, but this also yet has to be implemented. When we go into what AI can do, then we also have to speak about levels of autonomy. So level 1 would be data presentation. So this would be, for instance, AI on the screen highlights an area of interest of prostate biopsy, says, well, look here. Level 2 is already providing clinical decision support. So the AI is telling you, this is cancer on the prostate biopsy, and the pathologist takes a look at that. So things get left up to the algorithm as of level 3. So level 3 would be an example where the AI presents only cancerous tissue on prostate biopsy to be reviewed by the pathologist, and all the rest is discarded, is not even looked at. Level 4 would be that AI screens and independently signs out negative prostate biopsies. And level 5 is a full automation where the AI independently signs out all prostate biopsies. And as you'll see later on, we are quite a ways away from level 5. And what we're dealing with now and what our current guidelines deal with now are levels 1 and 2. And when using these algorithms, for instance, tumor detection algorithms, there are 2 approaches. So the first read, or firstly, usually the second read approach is taken. So you have your slide, it's scanning, then the pathologist makes its diagnosis, and then it is checked by the algorithm, and then the final diagnosis is signed out. That's usually what happens when first implementing an algorithm. And once it is known a bit better, then a first read approach is used, where you leave the reading up to the algorithm, and then it is then checked by the pathologist and says, okay, you're good to go for the final diagnosis. And the AI and products are being developed very, very quickly. And one of the main drivers here has been the concept of grand challenges, because computational developers are very into these challenges. So it's kind of like a game. If you see how you participate, is you make a challenge, say, for instance, for automated Gleason grading, and then you read the rules, register, and join the challenge, can create a team, and submit your result and paper, and then find your score in the leaderboard. So it's kind of like, may the best paper win. And this has certainly driven the development of many different algorithms. So for the end, let's go into some real life examples. For instance, Ki-67 detection in breast cancer. This is a standard of care that every breast cancer specimen is stained for Ki-67. And basically, this is therapy relevant in hormone receptor positive, HER2 negative cancers. And depending on a cutoff, which is traditionally set at 14%, patients will or will not receive adjuvant chemotherapy. So what we did is we validated several products and wanted to compare how they performed on 2 different scanners. So we took 96 breast cancer biopsies, and we had a region of interest for the Ki-67. And in that region, there was a ground truth with a manual count of each and every positive cell, and also eyeballing. So, and this is what is done in practice. In practice, nobody does this manual count. Eyeballing was taken from the actual reports in our laboratory information system, and also done by 2 different pathologists. And again, different products were compared on 2 different scanners. So for the eyeballing, it was very interesting to see that the 2 pathologists and the data from the reports correlated very, very highly to the ground truth. And also both algorithms did very, very well on both different scanners. There were some discrepant cases. One problem was intratumoral lymphocytes that were wrongly counted as positive tumor cells, and also what we called brownicity. So that would be the hue or the extent of brown staining that was considered positive, and that was higher for the algorithm than for the ground truth. So these are 2 really fundamental issues that need to be addressed, and certainly reasons why anything by an algorithm actually really needs to be double checked by a pathologist. Here's another example of how an algorithm can help us in practice. So this is tumor budding, and tumor budding is defined as clusters of under 5 tumor cells at the invasive margin of cancers. Can be seen in colorectal cancer, and that's where most research has been performed. But also, for instance, in squamous skin cancer, tumor budding can also be seen. And we know that tumor budding correlates with a poor prognosis, and this is why consensus guidelines for its quantification were established in 2016. So quantification means it essentially needs to be counted. And tumor budding has since been included in many different guidelines, at least for colorectal cancer. So this means pathologists have to do it. And Probably not something that every pathologist loves to do because it can also be tedious work and time consuming. So this is an ideal area of AI or implementation for AI in the clinic. But there are some challenges. For instance, there is a high variation in size and morphology for tumor buds, despite a very clear definition, and also inter-observer variability on what constitutes a bud, even among experts. And since tumor buds are easier to identify with immunohistochemistry, cytokeratin immunohistochemistry, most algorithms for its detection have been based on immunostains rather than H&E. So this is an algorithm which is still under review, and it takes a semi-supervised approach, the so-called teacher-student approach, by taking two neural networks, and the first uses a small label data set to guide the learning process, which is a teacher, and what is called the student is a second data set, which is larger, and its purpose is to increase the robustness to recognize variations in the object appearance. So that is actually the one that performs the best. And the correlation with human tumor bud detection is, I guess you could say, acceptable. And we know that the AI always detects more tumor buds. So this is also something that really needs to be addressed. Say, if we were to include AI detected tumor budding in the clinic. And this will almost certainly be a topic in the next coming years. Another example algorithm is tumor detection of colon cancer in lymph node metastases. And this is also something that has been looked at by our group. And in clinic and sign out, if you have a case of colorectal cancer, this really could be your scenario that you have 6 tumor slides, and these tumor slides are giving you all the information on the cancer. And if you're in stage 2, meaning that you have no positive lymph nodes, then you have over 3 times as many slides with lots and lots of lymph nodes. This case has 88 lymph nodes. They're all negatives, something that is very time consuming to look at, but is giving you no additional information. So also an in-house algorithm has been developed to detect colon cancer in lymph nodes. So this provides you with kind of like a heat map where the algorithm is more or less certain on where the tumor cells lie. And this is also a semi-supervised approach, which is similar to the teacher-student method. This is a transfer learning model. So you have a pre-trained model, which is actually in this case done in breast cancer nodal metastases, and you give it to a second data set for fine-tuning. And this model achieved almost 100% sensitivity, a very high specificity on almost 4,000 slides. So what you're looking here is, if you are going to use such an algorithm for screening purposes, you want 100% sensitivity with an acceptable amount of false positive cases. And in our algorithm, or in this algorithm, the only missed true positives were cases like this one, where you have only very isolated tumor cells in lymph node sinuses. This could have been easily missed by a pathologist. So you could say that although we don't really have this data in the corresponding paper, this would approach the gold standard of pathologist. Okay, so to wrap up here, AI models in pathology rely heavily on machine learning and deep learning technology. Novel techniques are being developed all the time to overcome traditional challenges, like semi-supervised methods for data labeling, etc. And computational researchers and pathologists need to work closely together. I am a pathologist. My understanding of data science and of what our computational guys are actually doing is limited. I understand the fundamentals and the principles, but not the details, and vice versa. You cannot expect researchers or computational researchers to know exactly what can be recognized on morphology and what our needs are. So that's why we have to be in dialogue with each other all the time. At present, the main area of implementation is for routine tasks and everyday practice. So this is supporting a pathologist's capabilities in the extended tasks for instance, survival prediction or still a research topic. Current models still require pathologists for decision making, and the lack of generalizability is still the biggest hurdle for widespread clinical use of AI in routine, and all of these models need to undergo rigorous validation in correspondence to guidelines to prove their utility. So with this, I would like to thank all the people that are involved with digital pathology and AI at our institute, and you for your attention.
So, good morning, dear colleagues. I'm happy to present one of the courses about inflammatory dermatosis, lichenoid dermatitis first, or lichenoid diseases. My name is Peter Heuselmann. I've been dermatologist and dermatopathologist. I've been 21 years at Universal Hospital Basel, did their clinical dermatology education, of course, and dermatopathology, and since 2 years I'm in dermatology am Rhein and dermatopathology. So we first discuss lichenoid diseases, and I hope you understand me and see a little bit my face. We discuss lichenoid diseases or dermatitis, and I try to focus on the very most important things. When we talk about lichenoid, we have to encounter interface vacuolar or lichenoid dermatitis, and then we'll explain how they differentiate. And we can have also combination of those lichenoid patterns, for example, vacuolar and spongiotic, or lichenoid and spongiotic. And we will go through some slides and get the main importance of that pattern out. Of course, if we talk about histology, dermatopathology, and lichenoid patterns, and this is important, we have to be sure, we have to be clear and robust that we do not deal with other inflammatory patterns, let's say spongiotic or psoriasiform inflammation patterns. That is very important. So we go to the next slide. I try. Where does lichenoid patterns take place? You know, the structure of the dermis, epidermis, and subcutaneous fat. Of course, we can have the inflammation pattern, for example, in acute cutaneous lupus or graft-versus-host disease. At the interface between epidermis and dermis, we can have it in the deep and upper part of the dermis, and we can have it at the interface between follicular epithelia and the dermis. Of course, before you make the histology, you always have to think about what could you expect out of any specific disease. For example, if you encounter a person with drug eruption and maculopapular type, you should have an idea what you expect in histopathology. Also, for example, in fixed drug eruption, of course, also the other forms, syphilis, lupus, or pityriasis lichenoides acuta. We will see some examples. The approach is important. The first approach pattern is, if you look at the histology, you have to be sure that what you see is interface and not, for example, psoriasiform. If you think it's an interface dermatitis, you will have to make the differentiation of vacuolar or lichenoid type. Here you say it might be vacuolar, that is pouch inflammatory, so few cells, very few cells at the interface between dermis and epidermis. And then you have to know which cells. Normally in lichenoid patterns there are lymphocytes, and then you look for the reaction pattern. You look, for example, for necrotic keratinocytes, and a typical thing is, or a feature is, that the epidermis will have a normal cornified layer, and the stratum granulosum is very robust to view. An example too is you have the interface and you see a lichenoid pattern, for example in lichen planus. There you have a lot of cells, very lot of cells. So lichenoid means very heavy cell, and they do also impact the lymphocytes, and then you may see multiple keratinocytic necrosis or apoptosis, and you can have that, for example, in a solar lentigo, which is inflamed, what we call also solitary lichenoid keratosis. And the third example, if you have something like psoriasiform inflammation, if you look at the slide, and you have also lichenoid changes, and you see histiocytes, maybe lymphocytes, but also plasma cells, you know, then it could be probably something like syphilis. So generally speaking, in tumors, in oncology, in clinical dermatology, in inflammatory diseases, if you look at the slide, you should do it always blind. So take first the histology, look at the microscope, look what you see, think blind of possible differentiations. Then, after you have been clear with yourself and the histological slide, go to the clinical information, and then you try to correlate clinic and dermatopathology. So this is normally a very important tool. So you have to go so-called blind into histology. You should not read all the clinical information. You should not look at the clinical pictures first, but you should first see your slide and try to think about what you see. Try to think about robust. Is it something like inflammatory, something like lichenoid, not spongiotic, not psoriasiform? And then you try to be very clear in the differentials, and then you have to go to the clinical information and correlate. That would be the very robust thing. So if you talk about the main prototypes, you probably are familiar with that picture. This is on the left side lichenoid, on the right side vacuolar interface dermatitis. On the lichenoid side, on the left, you have the example of lichen planus. This is a very clear epidermis with a good stratum corneum and a compact autohyperkeratosis. And you see a lot of lymphoid cells, and you see the interface between the lymphoid cells and the epidermis. And when you look closer, you see apoptosis, keratinocytic necrosis. So this on the left side is the prototypic features of lichenoid interface dermatitis. On the right side, you see the typical prototypical vacuolar interface dermatitis. And you here see very few cells, very few lymphocytes being aligned at the epidermis, and you see a lot of necrosis and apoptosis. These are the red keratinocytes and the shrinking of the nuclei of the keratinocytes. So on the left, you have few cells, you have interface changes with apoptosis and necrosis of keratinocytes, and this is the typical signs of vacuolar interface dermatitis. This you would expect, for example, in graft versus host disease and in acute cutaneous lupus erythematodes. Prototypical sign, lichen planus. We know the clinic, we know the histology. It's a lichenoid interface dermatitis, and on the right side you see the polygonal red or purple papules, which can confluence and make also some reticular Wickham patterns, Streifel. Here is the prototypical thing or features of the vacuolar type. You see just some seconds ago the histology on the left side, and this is the correlation to the clinic. You will encounter on the right side 3 clinical pictures of a classical graft versus host reaction within the first weeks after allogenic transplantation. So in acute graft versus host disease, you do expect a pouchy inflammatory vacuolar interface dermatitis and not a lichenoid interface dermatitis, which you would expect in lichen planus. How to approach this lesion? So you know, and I told you, if you go to a diagnosis, histological diagnosis, you just look into the histology, and you see now an epidermis, you see a little bit inflammatory patterns, you see probably some kind of different inflammatory cells. It might be lymphoid cells, it might be some plasma cells, maybe also some histiocytes. So you could say, okay, I do not see any spongiotic lesion in the epidermis, I do not see any psoriasiform changes, but it might be some kind of changes which you would call interface changes of of the vacuolar type. And if you go closer, in the lower part you see a lot of plasma cells, and in the upper part you see it's marked some kind of interface changes, vacuolar degeneration of basal keratinocytes, and some cells, inflammatory cells, which comes to the epidermis. And you probably know that if you have interface changes, it might be very difficult to differentiate dermis with the infiltrate from the epidermis, and this is a very good example. And if you have some form of interface changes and some plasma cells, we are very close to the infection of syphilis, and I marked it here, the plasma cells with CD123, kappa lambda, and Treponema pallidum antigens, which could be shown by immunohistochemistry. This is also this is an example of secondary syphilis. You have on the left again the histology, plasma cells and minimal interface changes is very prototypical for secondary syphilis. On the right side you see the classical clinic without any symptoms and the palmoplantar involvement. If you have something like this is not often, but if you have a histology, some edema in the upper part, and if you go on the right side closer, you see a lot of dyskeratosis, apoptosis, necrotic cells, and very, very sparse inflammatory pattern. So very few lymphoid cells at this border. You have to think about different lesions, and if we see those histological changes on the left, which we just discussed, and go to eccrine coils in the middle part, and if you see then some neutrophils around the eccrine coils, and if you go to the upper part and you see that the eccrine ducts show some metaplasia, cornification, which we then call syringosquamous metaplasia, and then you would correlate this vacuolar interface changes at eccrine coils and epithelia, and you see this pattern, then this might be a drug eruption, or this might be an entity which we call neutrophilic eccrine hidradenitis, which can be one form of drug eruption or idiopathic disease, which shows some red, purple changes on palms and soles. If you go at a lesion like this, it's very difficult to say which pattern you encounter here, so it's nearly impossible. You just don't see an epidermis or a dermis, and you don't realize exactly where is the border between epidermis and dermis, and this can for itself be a hint or a tip to make a diagnosis of interface dermatitis. Okay, we go closer, and if you go closer, we see that there is a heavy infiltrate of mononuclear cells, probably lymphoid cells. Then we have difficulties to see a border between dermis and epidermis, but we see some cells going up, and the stratum corneum, which shows inflammatory cells and parakeratosis. So of course we have to go closer. And if you go closer, we see now in the lower part the lymphoid cells, some pigment, probably melanin pigment, and then we see the epithelia, which is mainly destroyed or lichenoid change. We see some lichenoid patterns here, vacuolar degeneration, necrosis of keratinocytes. We see some keratinocytes, and then we see inflammatory serum and cells within the stratum corneum. Of course, this is a very heavy reaction of the skin. And if we go a little bit deeper, we see also the lymphoid cells in the deep part around vessels, around eccrine and follicular drugs. And when you go for immunohistochemistry, we can see that the involved lymphoid cells, which do induce these interface changes, are mainly CD3, CD4, and CD8 T cells and no B cells. And if we see that pattern and then go to the clinic, we can try to make a robust clinical pathological correlation. This is a young female around 10 to 12-year-old. She has plaques and papules, hemorrhages on the trunk and proximal extremities, and she's otherwise healthy. She had an infection before, and if we go back to the histology, we know it's a heavy inflammation of the whole dermis. It's a heavy interface change, necrosis of keratinocytes, and then we are close to a diagnosis which you probably are familiar. It's pityriasis lichenoides acuta, which we know Mucha-Habermann disease. So we now go to the next disease. You see that here there is a very small inflammatory change. You see an epidermis on the left and right with red ridges, but the epidermal red ridges are here gone, but there is now an infiltrate with lymphoid cells and few histiocytes, but the inflammatory process is coming up and might destroy some red ridges. For some experts of you, you probably already know what happens. So we have a small interface up of here you see subocular degeneration of some keratinocytes, no spongiosis, no psoriasiform lesion. We see histiocytes, we see lymphoid cells, and some other cells, but this is very prototypical for a disease which we call lichenitidose, and this is a very easy diagnosis if you just look at the right part. But if you are to do the histology blind on the left side, those who know a little bit deeper histology and inflammatory patterns, also the form of lichenoid patterns, you know when lymphoid cells, histiocytes coming up and destroy some red ridges. It's very a narrow inflammatory disease, and you correlate that with the clinical pictures you are with the diagnosis of lichenitidose. This is another example. You have interface changes in the middle. You have the derm part, stratum papillare with lymphoid cells. You have here the interface between epidermis and dermis. You see some apoptosis keratinocytes. And this is because there is no heavy infiltrate, a prototype of vacuolar interface change. You see stratum granulosum is very heavy, and compact autohyperkeratosis, stratum granulosum, which is good or heavy presenting. It's a typical feature of interface changes. That's also important to know. These are the same pictures. You have interface changes on different parts. You have a robust stratum granulosum, and you have a compact autohyperkeratosis. And hyperkeratosis, compact and good, and a heavy stratum granulosum is a very prototypical sign of any form of interface dermatitis, say vacuolar or lichenoid type. And if you have this histology with that interface changes, you go to the clinical pictures, and then you might encounter an older male with symmetrical cutaneous lesions, hyperkeratosis, and you might have the possibility to see also the pictures. We have some heliotrope exanthem in the periocular region. We have the prototypical Gottron papules over the dorsal of hands, and we have some other reddish purple features on the skin. And then if you take all the information together, you know it's a prototypical side of dermatomyositis, whether it's paraneoplastic or not. So in the clinic and also in the routine of dermatopathology, it's always interesting to differentiate chronic cutaneous lupus of the head and lichen planopilaris. Chronic discoid lupus is a scarring hair disorder. Lichen planopilaris is a scarring hair disorders. You have the two clinical pictures, and I want you to know a little bit how to robustly differentiate those two entities by histology. You see on the left side the prototypical signs of lichen planopilaris, and the right side you see chronic discoid lupus. Left in lichen planopilaris you see the follicular hyperkeratosis, the inflammation and hyperkeratosis around the follicular structures, but not deep thicker tissue or scarring without any hair. So in lichen planopilaris it's prototypical that you at the border of normal hair or skin and involved skin you see the follicular hyperkeratosis as I show you here. It might be in a pattern distribution. Whereas the chronic lupus, it shows more areas of scarring without follicular structure, and if you go at the border it's not as in lichen planopilaris, so you mostly do not see hyperkeratosis of solitary follicular units. But this is the very important things. It is actually not too difficult to differentiate by histology lichen planopilaris. If you have that histology, you see, if I would show you the follicular structure, there's the inflammation and the interface inflammation, which will, of course, destroy the follicular unit, is exactly around the follicular structure. And wherever you cut the histology or the skin, you will encounter different forms of scarring follicular inflammation. Here on the right side you see muscular arrectorum pilorum, then you know a little bit how high you are in the skin. You see remnants of follicular structure, but you see also scarring, you see inflammation, and you know these epithelia are just remnants of follicles. This is not the normal follicular structure. Muscular arrectorum pilorum, lymphoid cells, scarring and fibrosis. This is a prototypical sign of lichen planopilaris. In chronic discoid lupus, it's a little bit different. If you see the follicular structure, you know, and you see that there is around the follicular structure also the inflammatory infiltrate. The interfollicular part is essential. We have the follicular part where the hair follicle is, but if you make the differentiation between lichen planopilaris and chronic discoid lupus, you look at the interfollicular part, like here and here. There you will have the possibility to make the differentiation. On the left side, this is the interfollicular part of lichen planopilaris on the right side. And you see, I showed you in lichen planopilaris, the hair follicle is destroyed by an lichenoid interface, inflammation around the follicular structure. But if you go at the interfollicular part, there is nothing, no inflammation in lichen planus on the left side here and on the right side. In lupus, on the lower part, there are changes, and this is most important. At the interfollicular part of a hypothetical patient with chronic discoid lupus, you will see and encounter interface changes, lymphoid cells, necrotic cells, apoptosis, hypergranulosis, which is a surrogate marker, as I told you, of interface dermatitis and autohyperkeratosis. And also in this part, interfollicular, you see in chronic discoid lupus, inflammatory cells, lymphoid cells, apoptosis, necrotic keratinocytes, hypergranulosis, and compact autohyperkeratosis. So this is the main change, and now you're robust. You can make the differentiation. On the left part, this is the clinical picture of lichen planopilaris and in the interfollicular zone you have no inflammation, and on the right part you have the vacuolar interface dermatitis. You have the atrophy or hypertrophy of interfollicular epidermis, might be a little bit atrophic, might be hypertrophic, hyperkeratosis, and this is the involvement of the inflammation of the interfollicular part. And if we try to reproduce now these learnings in the differentiation between lichen planopilaris and chronic discoid lupus, then we look at that histology. You see here, for example, a follicular structure. You see the epidermis, the interface between epidermis and dermis, and the lower parts. We just look now at the lesion. We have the follicular part, and in the follicular part we have the interface dermatitis. You have the destruction of the follicular unit, asymmetric destruction of follicular epithelium. This must be lupus or lichen planopilaris. We have the interface changes here, but where you don't encounter any follicular structure, you have also in the interfollicular epidermis inflammatory cells, and you know now what it is. We have the follicular epidermis in the middle, we have the interfollicular border between epidermis and dermis on both sides with inflammatory changes, and then you know this must be chronic discoid lupus and this cannot be lichen planopilaris. And then if you correlate with that knowledge to the clinical findings, then you see a patient with scarring, whitish lesions and hyperpigmentation, and this is of course a very prototypical clinical picture of chronic discoid lupus erythematodes. And I think that's the last slide. I hope I could give you some basic information of lichenoid changes. Always try to go into a histological slide, try to get out what do I see, try to get out if you see inflammation, is it lichenoid or is it something like spongiotid or psoriasiform. If you think it's a lichenoid disease, you have to go for, is it pouch inflammatory, say few cells, heavy changes with keratinocyte necrosis, apoptosis, then it's a vacuolar type, or do you have anything like heavy infiltrate like in lichen planus, and then you have the prototype of lichen planopilaris. So thank you very much for listening, and I will close now. So, good morning, everybody. We are coming to discuss spongiottic diseases. My name is Peter Heusermann. I have been 21 years at the University Clinic of Basel. I did there clinical dermatology and dermatopathology since good 2 years. I'm now in a praxis, Dermatologie am Rhein, and I do clinical dermatology and a lot of dermpath in our laboratory, Dermpath Basel. We discuss now spongiottic diseases, and we just go in. If we talk about histology, inflammation, or neoplasia, we have to talk about Bernhard Ackermann. He was dermatopathologist from the United States that died some years ago, and he introduced the so-called pattern analysis, which is very important. I have to say that if you go to make diagnosis and do dermatopathology, you just go into the slide and you try to get out what you see, and to try to get out what you see is the pattern analysis of Bernhard Ackermann. And now you have here 9 basic patterns. For example, the first one, the superficial perivascular dermatitis. So anything happens in a skin biopsy within the first 1 or 2 millimeters. If you go at the last, the paniculitis, you know that there is anything happens only in subcutaneous tissue and the epidermis and dermis is not involved. If you go at the fourth, the vasculitis, if you look at the slide, you will only encounter inflammation around vessels. So this is what we call, if you look at the first histological slide at the HE pattern, we just try to get the first information out. Where does anything happens? Does it happens in the very superficial part, around vessels, around follicle structures? Is it diffuse? Is it nodular? Is it just on the subcutaneous pattern? And then we have some ideas where we can go on. If you have, for example, a superficial perivascular dermatitis with only spongiosис, if you go and you have lymphocytes, you could, for example, think of seborrheic dermatitis. If you have a superficial perivascular dermatitis, some spongiosis, but you see a lot of eosinophils. However, if you don't have subepithelial blistering, you could, for example, think of bullous pemphigoid. Spongiosis is a term. You probably know that spongiotic disease, spongiotic dermatitis, is something correlating with eczema. Atopic eczema might be atopic dermatitis, and the term spongiosis is a histological term. So the histological term spongiosis mostly refers to the prototypical clinic of eczema, atopic eczema, contact allergic eczema, etc. So it's not generally used by all dermatopathologists. It's not so important, but spongiosis means a certain and specific pattern histologically, which most often will lead into a clinical picture which we call some form of eczema. Now, for example, acute contact dermatitis, you know, redness, blisters, itching, you can see spongiosis. There are a lot of marks, spongiosis here, so there are whitish areas between the keratinocytes, there are areas of no keratinocytes, some inflammatory cells, vesicles, then we have an edema here, and we have the marked spongiosis here. So if you remember lichenoid dermatitis, we just have anything, inflammatory things between epidermis and dermis at the basal cell layer. We do not have anything like blistering vesicles within the epidermis, which is the spongiosis. And this is a classical acute spongiotic process. If you have a lot of eosinophils, you might see anything in the clinical correlation of acute contact dermatitis. Here you have also the prototypical changes. You have in spongiotic diseases those blisters, inflammatory cells within the blisters. You have edema in between the keratinocytes, blisters, inflammatory cells. We call that spongiosis, and there is a so-called exocytosis of the inflammatory cell within the dermis and the perivascular area. You see the lymphoid cells, neutrophils, eosinophils, and those cells can go up through the epidermis and you will find them within the epidermis. And then this is the process of exocytosis of inflammatory cells within spongiotic or vesicular skin, vesicular dermatitis. So these are the prototypical signs of spongiotic dermatitis. This could be acute contact dermatitis. This could be this could be an acute atopic dermatitis. Again, if you encounter a little bit spongiosis, lymphoid cells, the exocytosis, this upcoming of lymphoid cells within the epidermis, and if you encounter here this ecrine structure, and you might see that the inflammatory process is around the ecrine duct, then you might probably think of miliaria. So miliaria, rubra, crystallina, profunda, but mostly the crystallina and rubra will show the exocytosis of lymphoid cells around the ecrine ducts in combination with some spongiosis, with some intercellular edema and the desmosome spines which are going wrong. So what exactly means exocytosis? And if we talk about exocytosis, we have a little bit to talk also about epidermotropismus. Epidermotropismus is a term which we mostly use in cutaneous T-cell lymphomas. That means that some cells will come up to the epidermis without any reaction pattern. So cells come into the epidermis, lining up the basal cells or coming as pottery abscesses. But when you encounter this is never something which makes inflammation, and exocytosis means more or less that most dermatopathologists think in exocytosis of an inflammatory process of lymphoid cells, other cell types, which comes from the dermis into the epidermis. Most often exocytosis is in combination with spongiotic diseases. And if you try to get answers what exactly is the differentiation between epidermotropism and exocytosis, you will find some different answers. I cannot go through all this. Most often there is an agreement that the histological term exocytosis is any process which leads into an inflammatory process. This can be a very broad area of information. Most often it is something like spongiotic dermatitis or eczema, and epidermotropismus is more or less a term which is correlates with an entity of cutaneous T-cell lymphomas. So the algorithmic method based on the pattern analysis, if you look into a skin, you have to look where the process finds the prominent features. If you think of spongiosis, you might encounter a superficial spongiotic dermatitis. You can have spongiotic features within the superficial and deep perivascular dermatitis. You can have spongiosis in correlation with a folliculotropic inflammatory cells or vesicular and pustular dermatitis. So these are 4 different patterns where all can be correlated and can include spongiotic processes. And we go through 1 or 2 of these. Of course, you should not go first to the clinical pictures. If you go to the clinical pictures, you know this must be pityriasis rosea Schieber, but you should go first to the histology. You see it's an upper inflammatory inflammation, so there is some involvement and some spongiotic features of the epidermis, and we would probably call that a superficial perivascular dermatitis. This is a very unspecific thing. It could be atopic eczema, it might be some differentiation, and it could be also this pityriasis rosea Schieber. If you go to a second clinical pictures, you try to get out what you see, and you have a superficial inflammation with vesicles. You have a lower part of inflammatory cells. You have also cells here. you have spongiosис only, lymphocytes predominant, you have moderate to dense infiltrate, but here formally you see it's not only the upper part, but it's always, and it's also the lower part. And then you correlate that with the clinical pictures, and then you might come into a differential in the clinical pathological setting of polymorphous white eruption, which is a prototypical inflammatory disease which shows lymphocytes in the upper and lower part, which shows some edema in the superficial dermal part. And if you see the papules, urticarial lesions, or macules at specific clinical sites, you can then correlate a pattern with spongiosis to a certain clinical picture. What you see here is a young female with some lesions on the face and upper trunk, and on the right upper side you have the histology. The histology shows some spongiosis within the epidermis, some cells, but also you have anything in the stratum corneum, and you have, and this is important, if you have spongiosis in the epidermis and you see neutrophilic inflammation in the stratum corneum, some similarly within psoriasis, then you have to think about dermatophytosis. Of course, this is not a difficult case. You would suspect dermatophytosis if you just look at the clinical pictures, but you see the histology, you might go for a pass examination, and then we will find out that there are a lot of hyphae, dermatophytes and spores, and then you can correlate with the clinical pictures. Another form of spongiosis, if you go first to the histology, you will see that the main process will be around and within the follicular structures, and you see edema, spongiosis, lymphoid cells, and might be some mucin if you stain for mucin. And if you have the prominent follicular inflammation with mucin, lymphocytes, and spongiosis, then you can think of alopecia mucinosa. You go then to the clinical picture, and you come up with an entity like this. So I don't go too strong within this literature. Geroni made with some colleagues, 9 dermatopathologists, a study where they all looked for 100 biopsies in inflammatory skin disease, so only inflammatory, no tumors, no melanoma, no lymphomas, but inflammatory skin disease like lupus, psoriasis, eczema, drug eruption, etc. And they looked for 100 biopsies in the first round without clinical pictures, and in the second round with clinical pictures. And you will see, if you look at the slide on the left side, the correct diagnosis of all these 9, if they did not get clinical pictures, if they just had to make a diagnosis by histology, it was lower than if they had the chance to make the histology first and then get the clinical pictures. So, for example, the first dermatopathologist had, without clinical picture, 31 correct diagnoses out of 100, and he could improve to 58 correct diagnoses out of 100 biopsies. And there is another one, for example, Mr. 4, he had 44 correct diagnoses without clinical information, and if he had on the clinical information, let's say within a robust clinical pathological setting, he could improve. And this is important to know, of course. However, there are very few changes from correct diagnosis to wrong diagnosis if you go from histology first, and then to the clinical pictures, and to make a clinical pathological correlations. Within 80 to 90% you will be more correct, but of course it can be also the counterpart. In another study two colleagues, two experts reviewed 100 inflammatory biopsies, a retrospective analysis, again, a first round without clinical information, and in a second round, you see the histology first, and then you get the clinical information. And also here, the blinded correct diagnosis without any histology, without any clinical pictures was about 55%. And if they get the clinical information on top, they could improve from, let's say, 55 to about 75 cases. So the clinical information as add-on is very important, of course, not for pathologists, but for dermatopathologists, which have a good background in clinical dermatology. However, please do not first read clinical information. Please do not first get to the clinical pictures, because you will be biased when you go to the histology. Bias is extremely critical. So first go into histology, read the patterns, try to get out what that could be in the differentials, and then go to the clinical information. However, out of those two studies, there are some histological patterns or diagnoses which are easy, like lichen planus, like leukocytoclastic vasculitis, which is easy to diagnose on a pure histological background on the left side. But on the right side, and this is important, for example, spongiotic dermatitis, eczema, atopic eczema, but also psoriasis, it is not so easy out of the histology alone to get a robust diagnosis. So here it is in the so-called bad pure histological diagnosis. You have as add-on the need of clinical information and pictures to make a good clinical pathological correlation and diagnosis. And I can tell you this is most important also in drug eruptions. Algorithmic approach in pattern analysis. You know, spongiotic patterns can be in the superficial part, in the superficial and deep part. It can be only in the follicular part, and it can be in correlation with vesicles and pustules. That you always have to know. And if you see a histology like this, you see fibrin crusts, parakeratosis, exocytosis of lymphoid cells, and an edema. This is very unspecific. We try to get out. You see a histology which I just showed you, which is not specific, but we just call it spongiotic disease with crusts, lymphocytes, spongiosis, etc. It's a superficial pattern. And when you see in a second round this colleague or this young man, you see some kind of eczema, which most probably, if you look at the distribution, will lead you to a diagnosis of atopic dermatitis, and then you go for the other signs of atopic dermatitis, for example. Here you see a superficial perivascular pattern. You see mononuclear cells, some eosinophils, a lot of lymphoid cells. Then you see some hypergranulosis and compact autohyperkeratosis. If you see hypergranulosis on compact autohyperkeratosis, I told you these are surrogate features also of lichenoid dermatitis, like vacuolar or lichenoid dermatitis, switching cancer in lichen planus or graft-versus-host disease. So if you correlate superficial perivascular lesions, some acanthosis, very few exocytosis of cells, very few edema, so minimal spongiform features with hypergranulosis, you need clinical information. I can tell you, you will be not able to make a correct diagnosis, and this is also true for very experienced dermatopathologists. And if you go to the clinical picture of this 72-year-old woman, this is just a person which has eczema, which has a photoaggravated type, and this is a photoaggravated type of atopic dermatitis, and this is very difficult on a pure histological background if you think at the histology I just showed you. So You just can say out of the histology, it's not a pure lichenoid type, it's no malignancy, it's no neoplasia, it's inflammation, it's inflammatory features in a superficial part, minimal spongiform changes, but the acanthosis and minimal lichenoid part can, in the correlation with the clinic and the anamnese, lead you to an atopic dermatitis in a photoaggravated form. This is more prototypical. You have a classical acute spongiotic and vesicular dermatitis. You see spongiosis, vesicles within the epidermis. You see a lot of lymphoid cells and eosinophils. And of course, you could think of, for example, acute contact dermatitis, allergic contact dermatitis. In eosinophils, you always have to think about dermatophytosis. In eosinophils and spongiosis, you always have to think about bullous pemphigoid, for example. But you also try to get out that there are some dyskeratotic cells. And if you have spongiotic vessels, eosinophils, you have to think about all these entities. And the most important thing is the age of a patient and the dyskeratotic cells, which I just showed you before, and only, I would say, only one of those differential diagnoses come up with necrotic cells, and this is the incontinentia pigmenti with the eosinophilic pustulosis. And this is the clinical pictures. I don't go too much in the details. Incontinentia pigmenti is an important genetic dermatosis with different clinical stages, vesicles, plaques, hyperpigmentation and hypopigmentation, and correlating to the clinical evolution. You will find in the acute first part the eosinophilic spongiosis, vesicles, etc., like I showed you before. If you have a biopsy like this, you see follicular structures, sebaceous glands, you see lymphocytes, you see a prominent perifollicular inflammation in the upper part, you see fibrin crust and spongiosis, and the prominent changes in the follicular ostia with serum crusts and lymphoid cells. And if you go a little bit closer, you try to get out the Malassezia furfur, and then you're close to a diagnosis, spongiosis, superficial perivascular dermatitis, a follicular prominence of inflammatory changes, fibrin crusts, etc. Then you will be nearly in spongiotic diseases and seborrheic spongiotic eczema, and this is the clinical picture of that male who adequately shows clinical features of seborrheic dermatitis, which you can try to get out on a pure histological background. If you now change from Bernie Ackerman's pattern analysis, I just want to prominently take out David Whedon, which is an experienced dermatologist. He did a lot of books, and we just look at his way of thinking of spongiotic reaction pattern. So Whedon is from, I think, Australia or New Zealand, and he knew exactly the pattern analysis of Bernhard Ackermann, which is most often done, which is very important, but he has some different form to go into spongiotic reaction pattern. And again, the spongiotical tissue reaction is a histopathological concept, not a clinical one. Spongiosis is mostly correlated to the clinical eczemas, but not all. But eczema is the term which we use in clinic, and spongiosis is the term which we use in histology. Whedon, he said we have some spongiotic reaction pattern, blisters, exocytosis, crusts, etc. And he prominently differentiated between neutrophilic, eosinophilic, and miliarial and follicular spongiotics. And I will just present you some examples, like you have here a picture with spongiosis, edema between keratinocytes. You have a lot of neutrophils, few eosinophils, scattered acantholytic cells, and a sparse inflammatory reaction pattern at the superficial papillodermis. You could think of neutrophilic spongiosis. And then, of course, this is seldom. You have to encounter, for example, a disease of the autoimmune bullous IgA pemphigus. Of course, you can make only this diagnosis in correlation with the clinic, in correlation with the antibodies detected in a serum, and with a direct immunofluorescence. But in IgG or IgA superficial pemphigus, you don't need the prototypical epidermolytic changes or acantholytic changes, but you have the possibility to see the neutrophils, but you have to make the correlation with clinics and direct immunofluorescence and the precise determination of specific antibodies. If you have anything like this, you see an epidermis which is acanthotic, then you see a dense infiltrate of eosinophils in the epidermis and papillary dermis with some admixture of lymphocytes, and you have epidermal hyperplasia and papillomatosis. It's nearly impossible to say what it is, but you know this is inflammation, you know this has eosinophils, you know there is acanthosis, and then you think of some inflammatory differentiations, and then you go to the clinical pictures on the right side, and you try to get out what these clinical pathological correlation could be, and then you might come up also to an autoimmune bullous dermatosis, which is seldom. It's the pemphigus vegetans. And also here, how in autoimmune bullous dermatosis, autoimmune bullous dermatosis, you most often encounter a lot of eosinophils. But in this type of pemphigus vegetans, like in the IgA pemphigus, the most prominent prototypic features is not the acantholytic cells, which you expect in classical pemphigus vulgaris, but you might encounter neutrophils in IgA pemphigus and a lot of eosinophils in pemphigus vegetans. Miliarial spongiosis, again, you saw in the first slide some histology which takes out in account that the lymphoid infiltrate is actually correlated or around the eccrine ducts with spongiosis and lymphocytes, and then you have the perieccrine inflammation. Perieccrine inflammation, of course, leads in first part to miliaria differentials like miliaria crystallina or rubra. And if you have the histology, you have to go to differentiate the three prototypes of miliaria to the clinical pictures, and then it is easy to make the diagnosis of miliaria alba or crystallina in that specific clinical pathological correlation. If you have, for example, a histology with some spongiotic diseases, some inflammatory patterns, but also spongiosis within the follicles, then you have a folliculotropic type of spongiosis, and then you try to go to the clinical pictures because here it is very difficult again to go for an exact histological or clinical diagnosis, and then you have to encounter the clinical picture. And if you think about axillary lesions with papules which are very, very, very itchy, then you can make the process. Of course, Fox-Fordyce disease is a folliculotropic inflammatory disease, inflammation, a lot of itch, and then you correlate this histology with the clinical picture. And if you know a lot of clinical dermatology and dermatopathology, then it's very good to make a disease diagnosis of that Fox-Fordyce disease, which is a seldom disease. If you think about follicular spongiosis, this is difficult to see because you see some lymphoid cells, maybe some histiocytes, you see a follicular spongiosis, you have to go to the clinical pictures, and the prominence on the right side of papules, pruritic papules in a face, and the histology of follicular inflammation with a lot of eosinophils. You have to make the correlation of Fuji disease. You have to know that in the face, eosinophils can also be very prototypical. If you have tinea faciae, dermatophytosis, so please do always a pass stain to exclude dermatophytosis, and if you do not have that lesion, you can go for Fuji's disease or HEV associated eosinophilic folliculitis in this particular disease. So last or second last slide, you have again a classical pictures of a spongiosis within the epidermis. Again, you see the exocytosis of inflammatory cells from the dermis perivascular area into the epidermis, spongiosis, vesicles, edema between the cells. This is spongiotic dermatitis. This is typical prototypical lesions. You see something like vessels, but it's not so easy to go to the clinic. You would have difficulties to exactly say what kind of acute inflammatory process that is. It could be acute eczema, but you have to think on different seldom diseases. And please look exactly what you see: spongiosis, vesicles. Also here, is this exocytosis? Is this vesicle? You don't know exactly. But if you clearly look and might go for immunohistochemistry, then you see that these are nests of melanocytes. Now think of nests of melanocytes, junctional nevus, together with all these inflammatory cells and spongiosis, then you will come up with a myosin nevus, which means that there is an inflammatory process within the epidermal, within the melanocytic tumor or proliferation. Spongiotic changes within a nevus is called myosin nevus. And this was my last slide, and I hope I could give you some basic information of spongiotic diseases. Thank you very much for listening, and have a good day.
Welcome everybody to the next lecture dealing with the topic of cutaneous vasculitis. My name is Andreas Volz. I'm working in Basel as a dermatologist in Dermatologie am Rhein and as a dermatopathologist in Dermpath Basel. I have no conflict of interests. And so we start. Vasculitis is defined as an inflammation targeting the blood vessel walls and compromising their function. So, and this leads to hemorrhagic or ischemic events. There's a broad range of vasculitis. So we have on the one side self-limited disorders in one single organ, and on the other side life-threatening diseases due to multiple organ failure. The histologic features required for the diagnosis is on the one side a transmural vascular inflammation at the position of fibrin in the vessel walls, evidence of endothelial cell damage, and extravasation of erythrocytes. In 2012, the Chapel Hill classification of vasculitis appeared, and this is the essential diagram there, where the different kind of vasculitis are arranged in correlation to the affected vessels. So we have small vessel vasculitis, medium vessel vasculitis, or large vessel vasculitis, and the ANCA-associated small vessel vasculitis is here. And as you see, there are many topics we are dealing with in the next 30 minutes. 2018, there was an addendum published specialized on the cutaneous vasculitis. So we have here the small vessel, medium vessel, and large vessel vasculitis. And as you can see, the small vessel vasculitis has an overlap with medium vessel vasculitis, so that's not only restricted to the small vessels or medium vessels, but there's a certain overlap between the entities. This is a short comprehensive diagram where the vessels are located in the skin, so the epidermis and the surface, and here the subcutaneous tissue. And this is also in your handouts, so I will go on here. But what's most important is that when you get a biopsy to diagnose a vasculitis, it's important that you request a deep punch or an incisional biopsy, because with a shave biopsy, okay, no dermatologist would do a shave biopsy for diagnosing a vasculitis, but if you receive a shave biopsy, it's not possible to see the subcutaneous tissue, of course, and only with a deep punch or incisional biopsy you can just diagnose vasculitis correctly. Starting now with the small vessel vasculitis. Here, short overview, the addendum to the Chapel-Hill classification. That's the area we are dealing with. Chapel-Hill classification, and here you see it's the small vessel vasculitis, usually in the superficial dermis. So we can broadly categorize the small vessel vasculitis in 3 categories: immune complex associated, ANCA associated, and associated with connective tissue diseases or other etiology, for example, drug, malignancy, or infection. Starting with the classic leukocytoclastic vasculitis, everybody sees in the clinic. So the key features are here: perivascular infiltrate of neutrophils, the fragmented nuclear debris, so it's called leukocytoclasis, extravasation of erythrocytes, and the fibrin deposition in the vessel walls. And fibrinoid necrosis of the blood vessels is variable. It's important to know that the histologic features are dependent on the timing of the biopsy. Ideally, the biopsy will be from a lesion that's not older than 24 hours, because here are the most typical diagnostic features seen. And after 48 hours, the infiltrate is mainly composed of lymphocytes, but the earlier the biopsy is taken, in this case, it's the better. Not too early, of course, when you remember the life of lesions. So this is what it looks like in this in a biopsy. We have on the one side a perivascular infiltrate of the neutrophils. You can see here and here, and this is associated with the leukocytoclasis and the hemorrhage. As you can see here, the erythrocytes and a fibrin deposition in the wall. It's best seen in this picture. When you do direct immunofluorescence microscopy, you can find, for example, a T3 deposition around the superficial vessel's wall. Here's that's the epidermis, so you have here the superficial dermis correlated with the vessels in the superficial dermis here. So this is a picture I think you have seen many times, and it's important to know that the fully developed features are not always present. So early cases may show only a perivascular neutrophils, maybe leukocytoclasis and hemorrhage, but no fibrin deposition or vessel necrosis. And it's important to know that if the epidermis is ulcerated, then there might be another reason for this vasculitis. So it's a secondary vasculitis, because usually primary leukocytoclastic vasculitis rarely results in the formation of an ulcer. So it's important just to look if there's ulceration, and maybe the ulceration is the reason for the vasculitis and not vice versa. One special immune complex vasculitis is IgA vasculitis, so-called Henoch-Schönlein vasculitis, Henoch-Schönlein-Purpura. The pattern is the same like in classic leukocytoclastic vasculitis, but here we find a direct immune fluorescence IgA around the vessels, and this IgA vasculitis is typically seen in children, and from a clinical point of view, we have the extensor involvement with large mottled patches of purpura, and there's a involvement of the gut, kidney, and joint, presenting the clinical features. And here the correlation with the clinical history is critical, and just to distinguish from the classic cytoclastic vasculitis, the direct immune fluorescence is the key to the diagnosis, because we have seen here, or we see here, the IgA in the papillary dermal vessels. Almost all pediatric cases of vasculitis are IgA vasculitis, and of Schönlein-Purpura is more than 90%. Then we go further to the urticarial vasculitis. Patients with persistent urticarial plaques, chronic urticaria, may have urticarial vasculitis, and they have also systemic symptoms. These are common, and the key features from the urticarial vasculitis is subtle leukocytoclastic vasculitis, a mild infiltrate, and sometimes, typically we have, or not sometimes, but typically we have focal eosinophils and extravasated erythrocytes. And it's often necessary to cut to deeper levels to make this diagnosis. And the criteria are not so stringent than in classic leukocytoclastic vasculitis. So this is what it looks like. For example, that's a mild leukocytoclastic vasculitis, some neutrophils here, and the leukocytoclasis. We see the vascular damage and eosinophils, and there are extravasated erythrocytes, like you know from classic leukocytoclastic vasculitis. And here it's important to have the clinical presentation. So we have the lesions as classic urticaria, and the primary differential consideration is also urticaria, but as you know, urticaria has a similar sparse infiltrate, but no vascular damage. And presence of a few neutrophils with neutrophilic dust and extravasated red blood cells, they indicate more urticarial vasculitis rather than urticaria. So this is for comparison, urticaria looks like in this. So intravascular and perivascular neutrophils, no leukocytoclasms, no fibrin in the vessel walls, no expansion of the vessel walls, and no erythrocyte extravasation. And in contrast, we have this perivascular infiltrate of neutrophils with leukocytoclasis, hemorrhage, and the fibrin deposition in the vascular walls. Another differential diagnosis is the Sweet syndrome. Here are the key features: a diffuse infiltrate of neutrophils, leukocytoclasms, but no necrosis of the vessel walls or no primary vasculitis. And this is a picture of Sweet syndrome, and as I see that my inset here of the camera is overlying some of the pictures and text boxes, I would stop this so you know what I'm looking, and we just do this or try to give more space to the slides. So Sweet syndrome, that's the overview and the scanning magnification. Usually you have a diffuse infiltrate in the upper and the mid dermis, and this papillary dermal edema is also common. And when you compare leukocytoclastic vasculitis with Sweet syndrome, you have leukocytoclasms in both entities, but you have Sweet syndrome only endothelial swelling with extravasation of erythrocytes, but no fibrinoid necrosis of the vessel walls. And this fibrinoid necrosis is seen in a classic leukocytoclastic vasculitis. And this is the further differential diagnosis you have to keep in mind. So granuloma faciale and erythema elevatum duodenum, two entities with very overlapping features. Maybe it's the same disease in two different places. Granuloma faciale is, as the name indicates, located on the facial skin, and there are no granulomas on the slide. The granuloma is only in the name, and erythema elevatum duodenum usually is non-facial skin. Both have the same microscopic features of polymorphous infiltrate with neutrophils and eosinophils and plasma cells, and diagnostic key point is the sparing of the adventitial dermis. So this is called Grens zone, and in early cases you can see leukocytoclastic vasculitis with extravasated erythrocytes and hemosiderine deposition, and this contributes to this reddish-brown color of the lesions. And in chronic cases, there is a so-called onion skin fibrosis. This is a little bit more extensive in erythema elevatum duodenum and then in granuloma faciale. So this is the picture of the granuloma faciale EED with this classical Grens zone. So this the adjacent dermis from the epidermis is free, and this is also to the follicular epithelium. Here you also see this Grens zone on this mixed infiltrate with neutrophils and eosinophils in a dense fashion. So this is, as I said, leukocytoclastic vasculitis. You can see polymorphous infiltrate and the Grens zone. These are the features in the early lesions, and when going on to the chronic lesions don't have vasculitis anymore, but this so-called onion skin fibrosis, as seen here, you have neutrophils and leukocyte classes in the skin, but no true vasculitis anymore. And this concentric onion skin fibrosis, that's very typical for the chronic stage of erythema elevatum duodenum or granuloma faciale. So, practical tips for these entities. The polymorphous infiltrate is the key to the diagnosis. So neutrophils, eosinophils, and plasma cells, lymphocytes, and so on. Then you have this Grenz zone, and this polymorphous infiltrates helps you to distinguish granuloma faciale from Sweet syndrome. And the vasculitis you may see in early lesions, but it's rare to see other forms of vasculitis in the face. Cryoglobulinemia is a systemic disorder in which immunoglobulins precipitate at cool temperatures, and the patients suffer from systemic manifestations. Usually we have the distal extremities, upper and lower extremities, where the cryoglobulinemia can be seen. Cold weather is one trigger, and there are two types, or three types. Type 1, we have increased IgM usually, and this is secondary to our underlying disorder, usually hematologic disorder. And type 2 and 3, yeah, we have monoclonal IgM or IgG, IgM polyclonal directed against polyclonal IgG, and this is secondary to an underlying infection or autoimmune disorders. And type 1 has no vasculitis, only hyaline inclusions in small and medium caliber vessels. And type 2 and 3, we have combined thrombosis and leukocytoclastic vasculitis. So direct immunofluorescence studies revealed intravascular immunoglobulin deposition, and cryoprecipitate is PAS positive and diastase resistant. And this is what it looks like. And these are these hyaline thrombi within dilated dermal vessels, as you can see here, and this is the PAS staining, where this precipitates is PAS positive. You can see no true vasculitis here. So this is cryoglobulinemia type 1, and this is type 2, an example for type 2 cryoglobulinemia. So we have here also an occlusion, but now there's leukocytoclastic vasculitis seen here. And when you're doing direct immunofluorescence, you can see the intravascular Th3 deposition, and here it's IgM. Coming from the small vessel vasculitis, we now switch to the small to medium vessel vasculitis. So here we are dealing with the ANCA-associated vasculitis. These are as a group of vasculitis associated with ANCA, specific for myeloperoxidase MPO. It's called P-ANCA or proteinase 3 or C-ANCA. And in contrast to the immune complex vasculitis, there's no or only little immunoglobulin deposition in the vessel wall. So the major clinical variants we are discussing is the granulomatosis with polyangiitis, the eosinophilic granulomatosis with polyangiitis, and the microscopic polyangiitis. The granulomatosis with polyangiitis was formerly known as Wegener's granulomatosis. This is an necrotizing granulomatous inflammation involving upper and lower respiratory tract, and a necrotizing vasculitis affecting small and medium-sized vessels. And very common, there's necrotizing glomerulonephritis. And the most important thing to remember is that the serology for C-ANCA is most specific for GPA. And this is what it looks like here in the histology. So the key features are this leukocytoclastic vasculitis involving the superficial and deep dermis. And now it's clear that with a shave biopsy, as I mentioned on slide 4 or 5, it's not possible to distinguish any leukocytoclastic vasculitis that's going deeper from a superficial one and so on. So here, as you see here, it's important to go into the fat, into the subcutaneous fat tissue to have the complete vessels from the skin to make your diagnosis. Because in deeper vessels you have sometimes this necrotizing vasculitis, and pyoderma gangrenosum-like ulcers may be present. There's palisading granulomatous inflammation seen, but a true granulomatous vasculitis is rare when dealing with skin biopsies. Here you can see this vasculitis with a necrotizing vasculitis with a widespread fibrinoid necrosis affecting a larger vessel from the middle of the dermis or deep dermis. And this is detail. Here you have also fibrinoid necrosis. You can see the infiltrate with neutrophils and lymphocytes, histiocytes, plasmacytes, and the neutrophils within the vessel wall here, erythrocyte extravasation, as you know already. So the practical tips here for GPA, the histologic findings are very variable. So it may present with only one of the histologic features, and usually the leukocytoclastic vasculitis, but it's important to have a correlation with the clinical presentation and especially with the serology here, the C-ANCA. That's most important to know here. When dealing with the next of the ANCA-associated vasculitis, we come to eosinophilic granulomatosis, also known as Church-Strauss syndrome. And here you have systemic symptoms like asthma, sinusitis, and eosinophilia. And 65% of all cases, just around 65% are associated with the P-ANCA expression. So key features are eosinophil-rich vasculitis in the superficial to mid-dermis, interstitial eosinophils, and variable flame figures. This is just one picture of eGPA. You see here the degeneration of the collagen fibers. It's called a flame figure, and surrounding histiocytes, eosinophil, granulocytes, and this vessel shows swelling of the vessel wall. And the eosinophilic granulomatosis with polyangiitis here shows also leukocytoclastic vasculitis, but numerous eosinophils, and this palisading granulomas with eosinophils and flame figures are characteristic, not invariable, but a characteristic feature. So if leukocytoclastic vasculitis has a significant numbers of eosinophils, then you should keep in mind that there's HGPA maybe. So we also have the need of the correlation with the history and especially the ANCA association. Differential diagnosis, usually the perivascular infiltrate of EGPA is much denser than in urticarial vasculitis. Both show eosinophils, and so such entities such as Wells syndrome should be considered, but Wells syndrome or other dermal hypersensitivity reactions have no vasculitis. That's one possible differential diagnosis. So this is Wells syndrome. You also see this eosinophilic infiltrate at mixed lymphocytes, histiocytes, and also here the flame figures. So flame figures, this palisading arrangement of the eosinophils and eosinophilic debris encrusting these collagen fibers. And because it's so nice, flame figures all over the dermis, but no vasculitis. Wells syndrome and no vasculitis. The third one I would shortly discuss is the microscopic polyangiitis. It's a systemic vasculitis associated with renal disease, also P-ANCA associated. And this MPA only shows a diffuse leukocytoclastic vasculitis in the superficial and deep dermis. And there are no histologic features for MPA you can separate from leukocytoclastic vasculitis or early granulomatosis with polyangiitis. So it's the correlation of the clinical presentation and serology is the critical. So to the last chapter, medium to medium or large vessel vasculitis. Here we have polyarteritis nodosa. It's also known as panarteritis nodosa. This is a systemic neutrophilic vasculitis involving the medium-sized muscular arteries in the subcutis or dermis subcutis interface. So the features can sometimes be focal, so you have to do deeper levels, multiple slides to look if you have or if you don't want to miss the areas of interest. And it's important to know that there are no associated diffuse paniculitis. One differential diagnosis is so-called nodular vasculitis or erythema induratum. There's a certain overlap, but the erythema induratum nodular vasculitis has an associated paniculitis, and in polyarteritis nodosa, this paniculitis is only in the adipose tissue surrounding the vessel. This is what it looks like. It's vasculitis affecting the arteries in the deep dermis and subcutaneous fat tissue. So it's no paniculitis in the adjacent fat tissue. And when you have this in detail, you see this necrotizing vasculitis with a full thickness inflammation and fibrinate changes. In contrast here, nodular vasculitis, also a vasculitis, but a small and medium vasculitis, but also paniculitis affecting lower legs and calves of women. And you have an acute vasculitis, but also there's an adjacent lobular paniculitis with granulomas and fat necrosis. And that's the clinical picture, and here we have the histological picture. Vasculitis, small mixed inflammatory infiltrate, and the mixed lobular and septal paniculitis you can see here. That's a complete different picture than when compared with polyarteritis nodosa. Here only a little bit of the inflammation is spraying over in the adjacent fat tissue, whereas here the fat tissue is completely inflamed. And the last one is the giant cell or temporal arteritis. This is a large and medium vessel vasculitis commonly affecting the temporal artery of older patients. Here we have a granulomatous infiltrate, typically affecting intima and media, and you find multinuclear giant cells and the destruction of the internal elastic lamina. This is what it looks like here. The biopsy to have diagnose the temporal arteritis, you have to biopsy of course, the temporal artery, and you see here this intensely inflamed muscular artery, and the lumen is completely occluded, and in the vessel wall you see these multinuclear giant cells. When doing elastic effervescence staining, you can see here the fragmentation of the internal elastic lamina due to this inflammation. So after 30 minutes, we're at the end of this presentation. This is the literature I used for the presentation, where the best pictures I've taken from these publications, because it's not easy to have a good picture from all these entities. And thank you very much for your attention. And if you have any questions, here's my email address. You can also send me an email. Thank you very much. warm welcome from Basel. My name is Andreas Volz, and I will discuss the bullous diseases in the next 30 minutes with you. So we're starting. I have no conflicts of interests. And when one wants to classify the bullous diseases, there are several options. Usually they are characterized by the location of the blister and the associated inflammatory infiltrate. And as you can see here, there are many differential diagnoses. So how to go on? Roughly speaking, we divide the bullous diseases now into intraepidermal blistering diseases and subepidermal blistering diseases, and we start with the intraepidermal blistering diseases. Some mechanisms of the intraepidermal blistering. So we have on the one side a spongiosis here. This means the presence of an intercellular edema, and the pronounced edema leads to a breakdown of the intercellular connection, and this leads to a vesicle formation. Then we know the mechanism of the acantholysis. So here a damage to the intercellular connections occur due to the deposition, for example, of immune complexes as seen in pemphigus, or gene mutations, for example, in epidermolysis bullosa simplex. So this leads to an attachment between the keratinocytes and the formation of rounded detached cells within the blister. Then we know ballooning degeneration, swelling of keratinocytes after infection with certain viruses, for example, herpes simplex virus or varicella zoster virus. Here, the vesicle formation is induced by a rupture of desmosomal attachments. And when we want to classify these blistering diseases, intraepidermal blistering diseases, as we can rely on this algorithm by Ackermann and co-workers, as you also have in your handouts. So now starting with the first one, Haley disease. Haley disease is caused by mutations in the ATP2C1 gene encoding a calcium channel pump, and it's an autosomal dominant disease. Usually you see small flaccid vesicles on an erythematous base, like here. There are wet macerated lesions, and the main locations are the axilla groins, or here in the interjejunous area. The mucosa usually is not involved. Haley disease shows a suprabasilar blister, irregular levels of separation within the epidermis, and the blister extends quite broadly with a prominent spongiosis. No acantholysis is seen in deeper parts of the adnexal epithelium because there's a reduced expression of ATP2C1 there. And usually we have mixed inflammatory infiltrate. So here in detail, the acanthosis with a full thickness, massive acantholysis, and this is often incomplete, and this pattern is described as the pattern of the dilapidated brick wall. The next one is Derma-Essen disease. Derma-Essen disease disease, we have also mutations in a calcium channel pump called ATP2A2. It's also an autosomal dominant trait, and this pump regulates cell-to-cell adhesion and differentiation of the epidermis. So mutations lead to an impaired desmosomal attachment. The clinical features are verrucous, hyperkeratotic papules in the seborrheic areas, for example, chest, face, neck, back, ears, and groins, and the lesions progress to crusted, greasy patches over time. Here we see the biopsy from Darier's disease, marked hyperkeratosis, and the next features are dyskeratosis, resulting in so-called corons and grains, a suprabasilar acantholysis, and sometimes the dermal papillae lined by a single layer of basal keratinocytes is the so-called pseudovillous formation. There's a lymphoid infiltrate, usually mild. Here you see the corons and grains, the dyskeratotic keratinocytes, the acantholysis, and the underlying lymphocytic infiltrate here. Corons are dyskeratotic keratinocytes with round nuclei and a surrounding pale halo, whereas the core grains are small oval cells with a dark basophilic cigar-shaped nuclei, and you find them often in the stratum corneum and granulosum. The next one is Grover's disease. Grover's disease is clinically characterized by intensely pruritic tiny vesicles and papules on chest, back, and thighs, and there's no specific pattern for Grover's disease. So the histologic pattern can mimic, on the one side, pemphigus, Darier's disease, Haley-Haley disease, and spongiatic dermatitis. So you sometimes find several patterns of the ones I discussed now in tiny regions, so the clinical correlation is essential. But despite from Haley-Haley and Darier's disease, Grover's disease is not an autosomal or not an inherited disease, and usually is seen in elderly people. That's a picture from Grover's disease here, so only tiny foci of involvement, and this is like a so-called pemphigus vulgaris pattern with the tombstone row, whereas here Grover's disease here with a Darier-like pattern with dyskeratotic cells, and you also see sometimes this pemphigus pattern with tombstone row even in one biopsy. Clinical pathological correlation is here essential. Darier's disease in the seborrheic areas, also in axilla and groins, Haley-Haley disease, mostly located in axilla and groins or submammarian areas, and Grover's disease here on the trunk. Coming to the epidermolysis bullosa simplex. Epidermolysis bullosa simplex is caused by mutations, especially in the keratins 5 and 14, but also blacktin mutations are known, and here it's important for diagnosis epidermolysis bullosa that one does immunofluorescence antigen mapping against the basement membrane proteins and epidermal components to determine the level of the skin cleavage. So the simplex, mainly mutations in genes coding for keratin 5 and 14. So the split occurs in the upper half of the basal keratinocytes, and there are autosomal dominant and recessive traits known. And if there's a mutation in BLACK-10, muscular dystrophy results. That's a clinical picture from a newborn child with epidermolysis bullosa simplex. Here, this is immunofluorescence mapping. You see the blister within the epidermis. There's an antibody with, against keratin 5, and the control here also with keratin 5, no blistering is seen here. And in this patient with keratin 14 mutations, so recessive mutations, no expression of keratin 14 is seen, but the blistering is obvious. Here you have the intraepidermal blister cavity, no signal for keratin 5 due to the complete absence of keratin 14, not keratin 5, keratin 14. And in the normal skin, the keratin 14 is regularly expressed, especially at the basal layer of the epidermis. Coming to incontinentia pigmenti. Incontinentia pigmenti is an X-linked inherited disorder. There are 3 stages of the rash known. The acute vesicular or blistering stage in the first weeks of life, a verrucous stage, and hyperpigmented stages, and also extracutaneous manifestations are associated with incontinentia pigmenti. In the blistering stage, the most characteristic feature is the eosinophilic spongiosis. As you can see here, spongiosis with eosinophilic granulocytes. This is very characteristic here. And here, massive intraepidermal blistering, spongiosis with keratinocytes, also dyskeratosis is seen, and a superficial infiltrate with eosinophils. So this is a cryofixation of this of a skin biopsy. You can see these artifacts, but the diagnosis can also be made here. Next one is the pemphigus vulgaris. There we have a suprabasal acantholysis with intraepidermal vesicle or bulla formation, and pemphigus vulgaris usually is caused by autoantibodies directed against desmoglein 3. Usually the disease occurs in elderly, and oral lesions are common in more than 80% of the cases. There are oral lesions. The desmoglein 3 here, as you can see, is a linking protein in the epidermal desmosomes, like in this graphic shown here, and desmosomes link keratinocytes to each other, and if autoantibodies destruct this linkage here, then blistering can occur. Pemphigus vulgaris can start with an urticarial stage where no blistering and no dyskeratosis is seen, only a superficial infiltrate of lymphocytes and eosinophils. And this pre-bullous or urticarial stage usually is not very distinctive, but in this case here, you see the blistering starts and the cleavage intraepidermal begins. And here, there you have the suprabasilar blistering, the roof of the blister is preserved, and you have the suprabasilar split with the acantholysis, and this is called a row of tombstones. And in the underlying dermis, you have this perivascular infiltrate of lymphocytes and eosinophils. If you're going direct immune fluorescence, you find here the so-called chicken wire pattern. A little bit more in detail here, these are IgG and C3 surrounding the keratinocytes, and these representing autoantibodies against desmoglein 3. The dissolution of the desmosomes by the autoantibodies and the retention of the hemidesmosomes lead to this so-called tombstone appearance, like a row of tombstones you can imagine. So you have two patterns. You can memorize the dilapidated brick wall in Hailey-Hailey disease and a row of tombstones in pemphigus vulgaris. Pemphigus foliaceus, the next one here, IgG autoantibodies against desmoglein 1 are the cause for acantholysis and cleft formation, but this is not in the suprabasilar layer, but it's in the granular layer or directly below the stratum corneum. There are no mucosal lesions because desmoglein 1 is much lower expressed in the mucosa than desmoglein 3. That's the histological picture here. We have acantholysis and the cleft formation within the granular layer or below the stratum corneum. We have only a few acantholytic cells, and sometimes the roof of the blister is very thin and missing, so it's called the pattern of the naked epidermis. And as you can see here, you have some scattered eosinophils in the upper dermis. So this is the direct immune fluorescence. You also see, let's say, a kind of chicken wire pattern, but here only in the upper part of the epidermis, and this is the reason desmoglein 3, the main autoantibody directly to desmoglein 3 in pemphigus vulgaris. Desmoglein expression is strong in the suprabasilar areas and diminished to the stratum corneum, to the superficial epidermal layers, whereas pemphigus foliaceus desmoglein 1 associated autoantibodies is just the other way around. So most expression of desmoglein 1 is in the stratum granulosum, superficial epidermal layers, and gradually decreases to the basilar layer. The next ones are bullous impetigo and staphylococcal skin syndrome. Bullous impetigo is secondary to Staphylococcus aureus, phage group 2. The Staphylococcus produces so-called exfoliatin. It's a protease that cleaves desmoglein 1, and therefore the blister formation starts or is seen in the granular cell layer with acantholysis, as you can see here. So you have subcorneal blister or pustules with acantholytic keratinocytes. You remember desmoglein 1 expression in the superficial part of the epidermis. Crusting with neutrophils occur, and if you do a gram staining, you find here gram-positive bacteria. In this case here, we have the high slide and the gram slide. cockle-scaled skin syndrome caused by Staphylococcus aureus group 2, phage type 71. This phage type 71 produces an exfoliative toxin, but the infection is at a distant site, and the toxin is released into the bloodstream, and therefore you won't find any bacteria here, so crumb staining is negative. And this toxin also cleaves desmoglein 3, but you have not mucous membranes are spared, so because of the expression of desmoglein 1 and 3. Herpes simplex and varicella zoster virus infection. So the epidermal intracytoplasmic edema, ballooning change, and the reticular degeneration with acantholysis are the key features. We have a superficial and deep lymphohistiocytic infiltrate, and the follicular involvement in the hair follicle sometimes is the only finding in varicella zoster virus infection. So this is also called herpes incognito. You have to look at the follicular epithelium, what's going on there. Here you see the ballooning degeneration of the keratinocytes with epidermal necrosis and the intraepidermal vesicle formation. Sometimes you can see these so-called ghost cells, necrosis of keratinocytes with this ground glass viral inclusions. Here, typical features of the infection with herpes simplex and varicella zoster virus. So now coming to the subepidermal blistering diseases, here also this algorithm proposed by Bernie Ackermann. To classify the subepidermal vesicular or bullous diseases, one has to keep in mind that there are on the one side autoimmune diseases like bullous pemphigoid or linear IgA dermatosis on the one side. On the other side, we have the genodermatosis from the epidermolysis bullosa group. And as here nicely annotated, we have autoimmune disorders and genodermatosis affecting the same targets. Starting with the bullous pemphigoid. Bullous pemphigoid is usually caused by autoantibodies directed against one of the two so-called bullous pemphigoid antigens, so BP1, 180 kilodalton protein, and BP2, 230 kilodalton proteins. And these proteins form, or these are hemidesmosomal proteins connecting the keratinocytes to the basement membrane, and binding of the antibodies at the basement membrane leads to eosinophil chemotaxis, release of proteases, and the blister formation. So this is the clinical signs. So there are pruritic tense bullae. They are distributed over the abdomen, the groins, axilla, and so on. Sometimes there's a preceding pre-bullous pemphigoid, only with pruritic erythematous wheals without any bullous or without any blister formation. This can look like this. So the pre-bullous lesions, you have the eosinophilic or eosinophil-rich infiltrate here in the upper dermis, sometimes exocytosis of eosinophils, maybe spongiosis can be seen, but no true subepidermal blistering. Here also the large amount of eosinophils in the papillary dermis. Then blistering occurs. Here we see the subepidermal blister with little or no infiltrate. There are types where there's no infiltrates, and we can see eosinophils and lymphocytes in the blister cavity and the superficial dermis. Spongiosis is seen, but no necrosis, except in older lesions where necrosis can occur. Here, nicely seen that the dermal papillas are preserved, and we have this eosinophils and lymphocytes in the blister cavity, and the basal cell layer is completely detached from the dermis. When doing immunofluorescence, you see a linear IgG along the epidermal junction. Here, that's the same pattern you can see for C3. And if you do indirect immunofluorescence on salt split skin, IgG is localized to the roof of the blister. Dermatitis herpetiformis, the next one is also autoimmune disorder associated with gluten-sensitive enteropathy. The target antigen is currently suspected to be epidermal transglutaminase 3, and the clinical features are tense pruritic papules with associated vesicles, sometimes bullae. Because of this intense pruritic clinic, often the blisters have been excoriated, and so you can only see crusted lesions. And this is the classical, typical histological picture. You have a subepidermal blister. As you can see here, you have a neutrophil-rich infiltrate in the blister cavity and in the dermis, and sometimes you see karyorrhexis. And what is the classical sign, the neutrophil microabscesses within the dermal papillae in the adjacent skin here. These neutrophil microabscesses, you can do direct immunofluorescence, and you see granular IgA deposition. And this is called the snow-capped mountain pattern. Because if you imagine a mountain in the summer with a snow cap on its top. Linear IgA bullous dermatosis, the next one. Histological identical to the bullous dermatosis of childhood. And the antigen is the LAD1 antigen is part of the extracellular domain of BP180 in bullous pemphigoid, and this is part of the collagen 17. The clinic is intense vesicles and bullae on erythematous base, like here, and this arrangement and polycyclic plaques resembling a string of pearls, as it's called, or cluster of jewels. In the histopathology picture, you have here the subepidermal blistering with neutrophils, sometimes eosinophils. You have a dermal, mainly lymphocytic infiltrate with some neutrophils. And when you do direct immunofluorescence, you have linear deposits along the epidermal junction with IgA. So it's also the same pattern for C3, but a linear IgA deposition, as the name linear IgA dermatosis indicates. Now coming to the group of the epidermolysis bullosa forms subepidermal. We have the junctional and the dystrophic epidermolysis bullosa, and it's a very heterogeneous group. Mutations are known here in laminin 332, collagen 17, alpha 6 beta 4 integrins, and in the leading to a junctional form of EP, and dystrophic forms usually are caused by mutations of collagen 7. When comparing junctional EP in the HE stains with dystrophic EP, this is junctional EP, this is dystrophic EP. Can you see any difference? Maybe you can. I can't, because to me they look very similar. So I want you to make the diagnosis. How can you do this? And here it's the most important thing. As the pathologist strategy for epidermolysis bullosa. In the HE slides, you only can have the idea of a genetic disease for epidermolysis bullosa. To determine the type, you have to do first immunofluorescence mapping on a fresh blister using a panel of antibodies against the structural proteins. They are known to be mutated in EP, so you see in this panel here. So then you can detect the level of the skin cleavage where the antibodies are binding. You can maybe get a hint if you see reduced IF signals, if there are mutations in one corresponding gene, and then you can do mutational analysis of the target genes. So it's nothing you can diagnose on one slide, and this can only be done in specialized centers with all this antibody to have. So one example here, the junctional EB type, formerly known as Hurlitz type. This is a complete absence of laminin 332 or laminin 5, as is formerly known. So you have a negative immunofluorescence signal here for this anti-laminin 332 antibody. You see the epidermis here, you see the subepidermal blister cavity here, and the dermis here, and usually you have a strong signal, linear expression of laminin 5, laminin 332, and here it's completely absent. And this is a hint for mutation in this gene. Here, another example, dystrophic epidermolysis bullosa. You see an anti-collagen 17 antibody at the blister roof. So this indicates that the cleavage site has to be here, but anti-collagen 17 antibody has a positive signal, and so you have to do one antibody after the other to check if there's a mutation there, or if there's an absence. Like here, patient's skin anti-collagen 7 antibody, no signal, complete absence of collagen 7, whereas in the normal skin you see this at the epidermal junction in this linear manner. This is specialized diagnosis, and after having the hint, you have a complete absence of one antibody, you can do mutation analysis. To the end, I come to the toxic epidermal necrolysis. This is predominantly drug-induced. There's a clinical picture of a massive 10. So this is a life-threatening disease, as you can imagine. You see a subepidermal blistering, and especially toxic epidermal necrolysis. So they have epidermal necrosis and subepidermal vesiculation, and also the next epithelium is here involved. The infiltrate. You see perivascularized, only mild. Some eosinophils are there, but you see here the completely necrotic epidermis. Only a necrotic epidermis in your biopsy. And what I want to point out, you see the stratum corneum is here completely autokeratotic, no parakeratosis. So this indicates the acute nature of this disease. Porphyria cutanea tarda is a photosensitive subabdominal blistering disorder on sun-exposed skin, usually involving dorsal hands, forearms, and the face. So we have a deficiency of the enzyme uroporphyrinogen decarboxylase. It's on the one side inherited or sporadic on the other side, and this leads to a deposition of uroporphyrinogen in the skin and accumulation of cytotoxic peroxides when exposed to the sunlight. This is one picture. So we have a subabdominal blistering with these preserved dermal papillae. So it's called festooning and a paucicellular dermal inflammation. And what one can see here, these are so-called caterpillar bodies. These are PAS positive. And sometimes you have so-called hyalinization of the vessels, also PAS positive. And when you do immunohistochemistry, these caterpillar bodies are collagen 4 positive. They are remnants of basement membranes. And also here you see these vessels with the hyalinization. So then we come to the end. There are more and more diseases where blistering can occur, like in this list, but I hope I have given a short overview about the main and most important blistering diseases. And especially in the diagnosis of epidermolysis bullosa, don't worry if you see some of these diseases not every day. These are rare diseases, and diagnostic is not the easiest one, but especially epidermolysis bullosa, this is only done in specialized centers. I thank you very much for your attention, and I hope you enjoy all the other talks. And if you have any questions, here's my email address, and I'll try to answer your mail as fast as possible. Thank you very much.
Hello everybody, I'm Derma-Essen, and it's my pleasure to talk about panicolitis. What's the meaning of the word panicolitis? Does it come from the Italian word pane? So does it mean that if you eat too much bread you get inflammation and stomachache? No, of course not. The word panicolitis stems from the Latin word paniculus adiposus, which means the subcutaneous tissue layer. So panicolitis means inflammation of the subcutis. What are the physiological functions of the subcutis? On the one hand, it's a place of energy storage. Lipids are stored in adipocytes. Then the subcutis protects us from physical injury and has an important role in thermoregulation, insulation. If you want to take a biopsy from the subcutis, it can be tricky sometimes because the situation is that you are on the surface and you want to get more information about something that is far in the deep area of the skin. So a good idea is to take a deep longitudinal spindle biopsy Or if you're using a punch biopsy, it's a good idea to use the double punch technique. So you take the first punch, and then through the same hole, you take a second punch that contains more of the deeper tissue proportion. That way you can make sure that you really get also a part of the subcutis and not only the dermis and the epidermis. Panicolitis is usually classified into two main categories, into septal and lobular panicolitis, because the subcutis has subcutaneous septa. Those are important structures that are important for the stability. And on the other hand, it's the place of vascularization and innervation of that skin compartment. The lobi are mainly composed of adipocytes. And then there is a third category of panicolitis. Those are the panicolitis secondary to large vessel vasculitis. This is an overview of the most important types of septal panicolitis. There's erythema nodosum, necrobiosis lipoidica, scleroderma morphea, factitial panicolitis, and diseases such as nephrogenic systemic fibrosis that also mainly affect the septa. On the left upper part of the slide, you see the meshwork of septa. It's about fascia. It's an interesting anatomic compartment in many organs that has only recently been discovered to be extremely important for structure, for shape of certain organs and for their functions. The differential diagnosis of lobular panicolitis is much larger, as you can see on this slide. So most panicolitis mainly or exclusively involve the lobi. And these two examples are categorized into the group of panicolitis secondary to large vessel vasculitis. So let's start first with a few examples of septal panicolitis. The very most important type of septal panicolitis is erythema nodosum. You all know the disease. It can be induced by infections, by drugs, and this is a classic septal panicolitis. So on this slide on the right upper side, you see that the subcutaneous septa are enlarged. There is fibrotic tissue, there are inflammatory cells, and importantly, you will discover in active lesions granulomatose tissue reactions, granulomatose inflammation out of histiocytes, multinucleate giant cells, and the characteristic finding are these clefts, which you can see here in the middle upper part of the slides, surrounded by granulomatose tissues. These granulomas with these clefts are also called nichous radial granulomas, and they are usually in the septa or paraseptal location. Another disease that may lead to septal panicolitis is necrobiosis lipoidica. So it's a granulomatose disease, a deep-reaching granulomatose disease that affects the dermis. But if it extends to the subcutis, and that's very common, then it affects the septa. And the typical histological findings of necrobiosis lipoidica is a deep-reaching granulomatose inflammatory reaction interspersed with areas of necrobiosis. It looks a little bit like a club sandwich, which you see on the left-hand side. So there are alternating layers of granulomatose, inflammation, and necrobiosis. Necrobiosis means that these tissue areas are acellular, but you still see the structure. So it's not completely destroyed as it would be the case in colliquation necrosis, but you still can appreciate the collagen fibers, the tissue pattern, but it's not vital anymore. A third example of septal panicolitis is scleroderma, or its localized variant morphea, which is much more common. The first thing you will notice if you get a biopsy from scleroderma or morphea is the loss of the retraction artifact, meaning that the edge of the punch biopsy is rectangular and there is not a curve, so there is no shrinking or not as much shrinking during the process of fixation in formalin as it is usually the case in skin biopsies. So rectangular, and then most importantly there is an increase in collagen fibers in the dermis, and when it extends into the subcutis, mostly the septa are affected. In contrast to a scar, the elastic fibers are preserved, and this can be nicely demonstrated in stainings such as Verhoeven van Gießen or Elastica van Gießen stain, which you see on the right upper side of the slide. These dark fibers are the elastic fibers that are still there. There is also inflammation. Clinically, you see it on the border, that lilac ring, and histologically, there is some perivascular lymphocytic infiltration, and there is lymphocytic infiltration at the margin of the subcutaneous lobi. So let's now touch a few examples of lobular panicolitis. An important disease in that category is erythema induratum basin, which is similar to nodular vasculitis. It's a disease in which usually mycobacterial infection cannot be demonstrated. It's a type of lobular panicolitis. Clinically, it rather involves the dorsal side of the legs and not as erythema nodosa on the ventral side. The characteristics are a lymphohistiocytic inflammation in the lobi and associated vasculitis. Here in the middle picture you can see fibrinoid changes of that smaller vessel, and also you can see areas of necrosis which are quite common in erythema induratum basin. Another not so common example of lobular panicolitis is subcutaneous fat necrosis of the newborn. The characteristic findings are an admixture of granulomatose inflammation with multinucleated giant cells in the lobi interspersed with normal adipocytes, so it's a mixed appearance. And later on, in later stage, which you see on the left side, there are these crystal-like structures, so colostring structures, and a more dense cellular infiltrate and fewer adipocytes. Another disease in young patients is sclerema neonatorum. It's different from subcutaneous fat necrosis of the newborn. It doesn't have that degree of inflammation, and on the other hand there are lots of needle-shaped clefts within adipocytes. Usually there are very sparse or, as I said, absent giant cells in that disease. Another characteristic example of panicolitis, lobular panicolitis, is xylophagic histiocytic panicolitis. It's in that categories of diseases that show hemophagocytosis, meaning that histiocytes swallow cells of the hematological system, such as lymphocytes, which you can nicely see in that picture. A more common example of lobular panicolitis is pancreatic panicolitis. It's characterized by large colliquation necrosis of fat tissue in the lobular area of the subcutis. It has somehow a dirty appearance, so it looks smudgy, these dark basophil smudgy material, and complete necrosis of the adipocytes. That's another example of pancreatic panicolitis that's still active, so you see lymphocytes, histiocytes, neutrophils, and areas of necrosis. Here as well, that's an area where all the adipocytes are not vital anymore. You don't see any nuclei anymore, so it's just a picture of ghost adipocytes. So you still see some of the structures, and you see these basophilic blue granules, and these are granules of calcification, of dystrophic calcification, which is a common phenomenon in pancreatic panicolitis. The pathophysiology of pancreatic panicolitis is interesting, and it's not yet fully understood. So, as I said, it's a lobular panicolitis with extensive fat tissue necrosis. Pancreatitis leads to a release of pancreatic enzymes such as lipase, amylase, phosphorylase, and it's known that trypsin increases the adipocyte membrane permeability for lipase and other pancreatic enzymes, and that finally leads to induction of lipolysis within the adipocytes, to necrosis of these cells, and that triggers inflammation. But the exact mechanism and why in certain types of pancreatitis this leads to pancreatic panicolitis, and in other types of pancreatitis there is no panicolitis, that's not fully understood yet. Panicolitis, like T-cell lymphoma, is actually not a primary inflammatory process, but it's a neoplasm. But it also involves the subcutaneous tissue, the lobular part mainly. It's characterized by malignant T lymphocytes, and they show that characteristic rimming around adipocytes. Usually the lymphocytes show a predominant CD8 positive phenotype. Lupus panicolitis is another good example of lobular panicolitis characterized by lymphocytic and plasmacellular infiltrates in the lobi and paraseptal regions. Sometimes lichenoid inflammatory changes can be seen in the hair follicle epithelium or in the interfollicular epidermis, and usually there is a lot of mucin deposition in the tissue. Another example of lupus panicolitis, you can see lots of lymphocytes, a few plasma cells, and here you also see mucin, which is blue in the Alcian blue stain. Sometimes it can be hard to distinguish panicolitis like T-cell lymphoma from lupus panicolitis. So the characteristics are that the cells are atypical, they show an atypical cytomorphology in T-cell lymphomas, and they are CD8 positive usually, whereas in lupus panicolitis it's a mixed infiltrate of B and T lymphocytes, and there is normal cytomorphology, and there is a staining CD123, which stains plasmacytoid dendritic cells, and that's another ancillary testing, a helpful staining to make the diagnosis of lupus, because lupus shows clusters of these cells, whereas other chronic inflammatory processes or also panicolitis like T-cell lymphoma doesn't show that phenomenon. Don't forget infectious panicolitis. It's also usually a lobular panicolitis characterized by suppurative inflammation, meaning lots of neutrophils, and sometimes granulomatous inflammation. So if you see those two inflammatory patterns stain for microorganisms, on this slide you can see acid-fast rots in the Nielsen stain, and it's a mycobacterial infection. It's atypical mycobacteria in the skin. Panicolitis means inflammation of the fat tissue, but does the adipose tissue also actively contribute to inflammation? Yes, we all know that this is the case. So adipocytes are hormonally active cells, and we know that obese patients, they are in a state of chronic inflammation. They have higher levels of inflammatory cytokines such as TNF-alpha, IL-1, IL-6, elevated CRP, and acute inflammation, when it becomes chronic, can lead to a couple of diseases such as some types of cancers, like prostate cancer, breast cancer, cardiovascular disease, so it makes patients sick. Adipocytes are also important immune cells and are actively involved in skin defense against microbes and in wound healing. It's an interesting field. We know that adipocytes are not only storage cells, they can produce lots of interesting peptides that affect the innate immune system. Teru Nakatsui has published a lot on this topic. This is an interesting paper recently published in Nature Communications showing that the skin is not sterile. There are microbes in different layers of the skin, also in the subcutaneous tissue. And Teru could show that the skin microbes induce antimicrobial responses, and that adipocytes are important cells that can produce antimicrobial peptides. There's an interesting review article showing that bacteria that get into the skin from the surface of the skin activate pre-adipocytes to become dermal adipocytes and inducing production of antimicrobial peptides such as cathelicidin that then lead to protection against skin infection. There is also an age-related variability of innate immune function depending on TGF-beta production by dermal fat. So you see that the subcutis is not only a place of storage, but it's an important place of immune defense of the skin. So part 2 of the functions of the subcutis is that the adipocytes are hormonally active cells. They are involved in several processes of inflammation, and they are directly involved in skin immune defense and also in wound healing. So the chapter of panicolitis is always in progress. There are always new types of panicolitis, as it is the case with the recently emerged COVID-19 disease that has led to several types of panicolitis. We all know that COVID-19 can be accompanied by frostbite-like rashes. And it's also a type of panicolitis that looks also histologically like pernio, like frostbites. Then COVID-19 disease has led to several cases of erythema nodosum, typical classical types and also atypical types, and another entity of COVID-19 associated panicolitis are cases of eosinophilic panicolitis that can be seen in several types of hypersensitivity reactions. So as I mentioned before, these are case reports of these entities. So there was a patient that developed erythema nodosum like lesions on the legs 3 weeks after diagnosis and onset of the COVID-19 disease. And in contrast to the normal erythema nodosum that is usually rather on the ventral side, it's more multifocal and more on the dorsal sides of the legs in this patient. However, histologically, it's completely a similar picture as classical erythema nodosum induced by SARS-CoV-2. That's one of the cases I mentioned, a case of eosinophilic panicolitis, so lobular panicolitis with lots of eosinophils. So there are, of course, several more types of panicolitis, and today I could discuss only a few of them. Of course, there is, for example, also sarcoidosis that can affect the subcutaneous tissue. In that case, you would also see lobular panicolitis that has sarcoidal granulomas, meaning naked granulomas in the lobi of the subcutaneous tissue, and many more. I give you this table from Wheaton's Skin Pathology book, which gives you a nice overview of many of the discussed types of panicolitis and a small summary of the histological characteristics that can be seen in these types of panicolitis. So, in summary, it's good to classify always into septal and low lobular panicolitis, and then if you have done this distinction, check for certain characteristic histological features that can lead you in the one or other direction and help you establish the diagnosis of a specific panicolitis. So I hope that after my talk you will not be in panic anymore if you hear the word panicolitis, or if you realize that you are dealing with a type of panicolitis under your microscope. And yes, thank you for your attention, and I'll be happy to answer questions. If you have any questions, you can always contact me directly through my email address, beta-mühleisen@usb.ch. Have a great day. Welcome back. My next talk is about collagenosis. So, have you all had your daily collagen drink? There are cool products out there. This one is called Beauty Collagen Mix. It comes from the Swiss Alps, and it's available in different flavors. Here's berry vanilla, but it's also available in chocolate. So if you want to drink such products every day, it's good that they come in different flavors. Collagenosis in our discipline means diseases of the collagen. Collagen is an important part of the skin tissue. About 70% of the dry weight of our skin is collagen. There are 3 structural collagen types, types 1, 2, and 3, and they are composed of alpha chains that are coiled to helices, to triple helices. These proteins are secreted from fibroblasts, and then in the extracellular matrix, collagenases cleave them to form procollagen, and then they are associated in a longitudinal way to form collagen fibers. Furthermore, there is cross-linking of the amino acids lysyl and hydroxylysin to increase the strength of these collagen fibers. In skin, type 1 collagen is the most abundant form. It accounts for about 80% of our dermal collagen. It's responsible for the tensile strength. Type 1 collagen is always composed of 2 identical alpha chains and a different chain, which is then coiled to a helix. Type 1 collagen, the gene for it, or the genes for it, are located on chromosomes 7 and 17. The second most important dermal collagen type is type 3. In adult skin, it accounts for about 20%. In newborn, in fetal skin, about 50% of the collagen is type 3 collagen. Type 3 collagen is more important for control of the expansion and contraction of vessels, muscles, and structurally, type 3 collagen is composed of 3 identical alpha chains, and it's also located on another chromosome, on chromosome 2q. Then there are type 4 and 7 collagens, which you all know are in the basement membrane, and another dermal collagen important for us is type 17 collagen. That's important in bullous pemphigoid. Here's an overview of a classification of collagen disorders. So there's the group of scleroderma, morphea disorders, then the mimics, the sclerodermoid disorders, other hypertrophic collagenoses, then there are diseases with a loss or a reduction in collagen. They are called atrophic collagenoses. Then there are others such as perforating collagenoses and syndromes of premature aging that also have to do with collagen in skin. Let's start with a very frequent common disease. I also discussed it briefly in my previous talk. Systemic scleroderma, or its localized variant morphea. As I told you already before, one of the characteristic signs is that if you take a skin specimen, there is no retraction artifact. So there's a rectangular edge of the biopsy, and there is no shrinking, or not as much shrinking after formalin fixation as it would be in a normal healthy skin biopsy. There's an increase in collagen fibers. They show some homogeneous degradation, and it can extend into the subcutaneous septa. There's trapped fat tissue, trapped appendages, and the elastic fibers are preserved. There is some degree of inflammation in scleroderma around the subcutaneous lobi and around the blood vessels, and it's mainly lymphocytes, some histiocytes, a few plasma cells that are typical. On this slide you get a closer look to scleroderma. On the right hand side you see that very characteristic swollen appearance of the collagen bundles. They are to a certain degree homogenized. And another histological feature is an atrophy of sweat glands. So the eccrine sweat glands, which you can see are less numerous. And it's also typical that there is a straight line, a straight edge of that increased collagen in the dermis to the adipose tissue in the subcutis. So it's not infiltrating, and it's quite a straight line. Another form of collagenosis is mixed connective tissue disease. It's already clinically a variable entity, and the same is true for its histology. In early lesions there is usually impressive dermal edema, and then in older lesions there is an increase in the collagen. It looks sclerodermic, just as it is the case in scleroderma. In those cases that show lupus or lupus-like features macroscopically, also the histological aspect is that of lupus. So on the left and the middle picture you see impressive interface dermatitis with vacuolized basal keratinocytes, and around the blood vessels, perivascular and perifollicular, you see a lot of lymphocytes, these dense lupoid infiltrates. Eosinophilic fasciitis is another disease of the connective tissue that affects the collagen. Here again there is a life of lesion. Early lesions of eosinophilic fasciitis show predominantly an edema and eosinophilic inflammation around the fascia in the area of the subcutaneous septa, and sometimes extending up to the lower parts of the dermis. In longer standing lesions there is progressive fibrosis. The fascia will be thickened, and there are sclerodermic changes mainly in the deeper proportions of the subcutis and in the lower dermis. But usually still there is a lot of eosinophilic inflammation, also in older lesions. Atrophoderma pyrini-Passini is another disease that affects the collagen. The histological changes may sometimes be extremely subtle and hard to detect if you only have one lesional biopsy. So for that reason, if you suspect Atrophoderma pyrini-Passini, it's always good to get two biopsies, one out of lesional skin and another one out of normal skin. Or in an ideal case, you get a larger biopsy that maybe has on the left side normal and on the right side lesional skin. In Atrophoderma, the dermis is atrophic, and this can sometimes be only seen indirectly as the subcutaneous tissue moves up and gets closer to the epidermis. Also, the structure of the collagen fibers is different. They are whirly and they are homogenized, as you can see on the right hand side picture on this slide. This is another example of Atrophoderma pyrini-Passini. This biopsy comes from the back, and knowing that this is skin from the back, the dermis is much too thin, and that's the characteristic change you will see in Atrophoderma pyrini-Passini. In contrast to Morphea, there is usually no inflammation in Atrophoderma pyrini-Passini. Sclerodermoid disorders are a group of diseases that mimic scleroderma, and in that group there is sclerodermoid GVHD, the group of chemically or drug-related sclerodermoid disorders, nephrogenic systemic fibrosis, scleromyxedema, and also after irradiation, chronic radiation dermatitis. Here's an example of sclerodermoid GVHD. As you heard in the chapter lichenoid dermatosis, GVHD is a lichenoid disease characterized by apoptotic keratinocytes in the basal layer of the epidermis, sometimes suprabasilar location. And in addition to those changes in the dermis underneath, you find the changes of scleroderma, meaning an increase in collagen, some degeneration of these collagen fibers. An important clue for GVHD, in contrast to lichenoid cutaneous drug reactions, is also the involvement of appendages, which cannot be seen on this slide, but which is very typical. Here is an example of a drug-related sclerodermoid disorder. In this case, the drug pentoxazine, which is an opioid that was injected locally, induced these changes. You can see an increase in collagen fibers, some homogenization of these collagen fibers that are not normal, no inflammation. And such changes can be induced by several drugs that are injected locally or by systemic drugs, and there are a lot of toxins also, sometimes in agriculture, that can lead to such skin changes. A very typical frequent disease that affects also the collagen tissue in the skin is lichen sclerosus atrophicus. The epidermal atrophy is one characteristic, however, this is only seen in longer standing lesions. There are lichenoid changes consisting of a vascularization of the basal keratinocytes in the epidermis. Here you can see that this zone is brighter. There's even a slit formation in the middle of this specimen. And then there is that very characteristic layer of sclerosis underneath the epidermis, accompanied by a lymphocytic band-like infiltrate underneath. In that zone of sclerosis, the elastic fibers are gone. So if you do Elastica van Gieson stain, you will see a loss or an impressive reduction of the elastic fibers. And that sclerosis zone is very characteristic. It looks very bright and reminds us a little bit of cotton wool, or it might also remind you of cotton candy. Today in Basel there is the opening of the Herbstmesse, so if you always get hungry and think of cotton wool when looking at a microscopic picture of lichen sclerosis, that's not a bad sign. Let's talk about a few examples of other hypertrophic collagenosis. A very common thing are scars, and scars can be hypertrophic. In a hypertrophic scar, there is an increase of collagen fibers, but also of the fibroblasts, which you can see on this picture. It's also an increased cellular component of these spindle cells. Characteristically, the fibroblasts and also the collagen fibers are orientated in a horizontal way, and the vessels are more in a vertical orientation. There are not many vessels on this picture here, but that's the typical configuration. In a hypertrophic scar, there are also no elastic fibers, in contrast to scleroderma, where they are preserved. If something looks like a scar, it could be a scar. However, there are a few differential diagnoses, especially if there is a scar without any history of trauma, and if it's in sun-damaged skin, always think of desmoplastic melanoma. That's a huge pitfall if you miss that. Of course, in an ideal case of desmoplastic melanoma, the spindle-shaped cells are atypical. They show pleomorphism, mitosis, but in such cases it's always good to stain for desmoplastic melanoma. SOX10 or S100 are the best markers for that purpose, to just rule out that malignant diagnosis. Also in scars, factor 13A staining is negative because that would stain dendritic cells in dermatofibroma, which is another differential diagnosis, and CD34 staining is negative for exclusion of the differential diagnosis dermatofibrosarcoma protuberans. So hypertrophic scar, very common thing in dermatopathology. Hardly ever anyone speaks about scars in histology courses. Keloids are not only clinically a distinct entity from just hypertrophic scars, but also histologically. The histological finding are these extremely enlarged, homogenized, and hypereosinophilic collagen bundles. American colleagues speak of bubblegum sign, and I have a Swiss colleague who always spoke about Servala sign if he saw these large bundles. So yeah, remember it. If you see these large bundles, that's the typical histological picture of a keloid. A collagenoma is a rather rare entity. It's a mixed group. Collagenoma is a type of hamartoma of the connective tissue. It's a variant of the connective tissue nevus, and there are different forms. There are familial cases, and those can be associated with a LEMS3 mutation and Buschke-Ollendorff syndrome. Histologically, there is an increase in collagen, and the collagen has a quite loose arrangement. So not like a scar where everything is horizontal, not like scleroderma, where it's also horizontal and degenerated. There is no inflammation in collagenomas. The elastic fibers are preserved, however, they are usually a little bit more widely separated. It's like a dilution phenomenon because there's more collagen bundles, then the elastic fibers are a little bit more widely separated. Atrophic collagenoses. Aplasia cutis congenita is quite a rare disease which affects newborns, usually the scalp or the head, and the characteristic signs are that already the epidermis is usually quite thin. There are no appendages, so there are no hair follicles on this picture you can see, and the collagen fibers, the collagen tissue is diminished and more loosely arranged. Focal dermal hypoplasia is a disease that's only focal, so there's just a small area where the dermis is reduced or missing, and this can also be seen indirectly, as in this picture, by the fact that the subcutaneous tissue, the adipocytes, the vessels from the subcutis, and so on, they move up to the epidermis. It's just a focal thing in focal dermal hypoplasia. Then there are a few other collagenoses. One of them is reactive perforating collagenosis. So this is a little bit a controversial entity. There are some authors that say this does not even exist. All cases of reactive perforating collagenosis are basically prurigo or folliculitis or other diseases that just lead to an ulcer and extrusion of collagen amongst other cells and parts of the tissue. However, for those that believe that reactive perforating collagenosis is a distinct entity, and I do believe that it is one, these are the histological findings. So reactive perforating collagenosis is a sharply demarcated lesion, and it shows acanthosis, a hyperplasia of the epidermis at the edge of the lesion, and sometimes it has like a picture of a downgrowth to that substance that will be eliminated, so like hands that move down and want to grasp it. Then there is collagen, which shows degradation and that basophil blue, dark blue color, and it's covered by a lot of cell debris, so remnants of nuclei of neutrophilic granulocytes, and so on. So sharply demarcated dark blue epidermal hypoplasia, and that vacuum cleaner sign. So it's a term that means like if a vacuum cleaner cleans some dust and gets it out of or away from the floor, here it's the epidermis that grasps down and tries to actively eliminate that collagen and get rid of it. Another extremely frequent disease that also affects the collagen is chondrodermatitis nodular helicis. In the beginning, there is usually an ulcer, also histologically, and then later on, there is fibrosis of the dermis and of the perichondrium, and most importantly, there are degenerative changes of the underlying cartilage and the perichondrium. The lesion on this picture is quite an established lesion that shows mainly the fibrosis. And yes, this is it. I hope I could give you an introduction to the most important collagen diseases in skin. Thanks a lot for your attention, and if you have questions, please send me an email at betamylaisen@usb.ch. Thank you.
Hi everyone, I will present you the histology of the granulomatous diseases. This is an overview of the content of the course. We'll first look at some non-infectious granulomatous disease listed here, and then the most common infectious granulomatous diseases. Granuloma is an immunological reaction pattern after several different stimuli. A histological picture present with histiocytes, epithelioid cells, and giant cells. It is always important in presence of a granuloma to rule out an infection with a PAS stain, Zell-Nielsen for mycobacteria, PCR culture as indicated, and to exclude also foreign bodies, especially with polarized light. Clinically, granulomatous disease are characterized by subcutaneous proliferation of histiocytes that can be revealed through diascopy. So when you press the skin with a glass petal, you can see this typically yellowish, brownish apple jelly color. We distinguish different types of cutaneous granulomas. There is the foreign body, palisaded, xanthogranuloma, sarcoidal, suppurative, tuberculoid, and not represented here, the interstitial type. We distinguish also three different types of giant cells that don't correlate necessarily with the etiology of the granuloma. There are the foreign body giant cells, where the nuclei are irregularly disposed. The Langhans giant cells, the nuclei are arranged in a horseshoe-shaped pattern in the cell periphery. And finally, the two-tone giant cells with a ring of nuclei with a central homogeneous eosinophilic cytoplasm with a foamy cytoplasms around the nuclei. So typically the foreign body giant cells are seen in foreign body reactions and two-tone giant cells in xanthogranuloma, but that foreign body giant cells can also be seen in other granulomatous. Some important aspect in the terminology, lupus vulgaris doesn't design lupus, but is another word for skin tuberculosis. Lupus perennial is also not lupus erythematosus, but is a sarcoidosis of the nose. Chilblain lupus is a lupus of the acral region, not to mistake for perniones or chilblain. There is a cold-induced acral skin damage. There is not related to lupus. And the definition that's useful for all granulomatous disease is necrobiosis. This is a morphologically altered collagen with a mild connective tissue degeneration. With the non-infectious granuloma, and the most common one, the granuloma annulare. Clinically, we distinguish the classical localized type. A generalized type can be diffuse, deep, located in the subcutis, and more rarely perforating or interstitial. These are some clinical presentation. You see this annular dermal proliferation without any epidermal involvement, right? No scales, can be light reddish or skin color. The center of the lesion is usually comparable to the outside. The lesion can be also very small, almost like small plaques, or can be broader and confluent. Histologically, we have a normal epidermis. We have dermal palisading granuloma surrounding necrobiotic zones with some neutrophilic debris, and importantly, mucin deposits in the necrobiosis. The granuloma are mostly superficial in the dermis and sometimes you can observe a few eosinophils. So here you see the normal epidermis and this roundish histiocytic proliferation, also with lymphocytes and eosinophils, and this central necrobiotic zone where we have the mucin in a special stain. So you have to imagine this palisading of histiocytes surrounding the central necrobiotic mucin-rich zone. Here another presentation, a bit more diffuse, always with mucin deposition at the center, so in the necrobiotic zones. Here you see the histiocytic proliferation. It's the more interstitial the granuloma is, the most difficult is it to see the mucin without the special stains. Another common granulomatous disease is necrobiosis lipoidica, typically characterized through brown, yellowish plaques located on the shins, often bilateral. And the difference also with granuloma annulare is that this lesion with time can ulcerate or are characterized by an atrophic epidermis that can then rupture. Histologically, we have an epidermis that's normal, with time can be atrophic or ulcerated. We also have, like in granuloma annulare, palisading necrobiotic granuloma in the whole dermis, so it's not only superficial, but it's superficial and deep. It's often arranged like a lasagna with different layers. We have perivascular lymphocyte with some plasma cells, but typically no mucin. These are examples. You see the normal little flattened epidermis with loss of greater ridges, and this granulomatous proliferation that goes from the upper to the deep dermis with this layering that we see at low magnification. If we go closer, we see the necrobiotic areas in the middle of the granulomatous zones, but they're more reddish. They don't have this bluish mucin-rich stain like granuloma annulare, and infiltrates are much more deeper. An important, although not so common, disease is a sarcoidosis characterized by the presence of non-caseating granuloma that affect multiple organs. They are listed here. The skin is affected in 20 to 35% of the cases. You see, the clinical presentation, the typical color of sarcoidosis lesion is this dark reddish, brown, yellowish plaques that can be also with an annular presentation, and in some cases you see already the atrophy of the epidermis can be mistaken in a case like this, for example, with a chronic lupus. Other lesions here with bacterial superinfestation explaining this yellowish crust, usually well demarcating brownish plaque with a positive sign on the diascopy and this brownish color. When are a bit deeper, they are less clearly defined. And a particular case of lupus pernio, the sarcoidosis of the nose. This is a closer view at the individual lesions. You see the typical diascopy with this yellowish apple jelly color at diascopy. The plaques itself caused by the confluence of dark reddish to brownish papules. Sometimes they are almost skin colored, but with no epidermal involvement. Histologically, is characterized by normal epidermis and dermal proliferation of well-demarcated naked granulomas with few lymphocytes at the periphery of the epithelioid cells. That's why they are called naked, because they have few inflammation around the granuloma. There are several histocytes and giant cells, but no necrosis, no necroptosis, and no mucus. So the first view of histology of sarcoidosis, you will think about the tumor, because it's a nodular proliferation occupying the whole dermis. When you go closer, you see this thin septa separating this nodular proliferation of histiocytes. And if you get closer, you see also the presence of giant cells, but only very few lymphocytic infiltration. Here you see also some sarcoidal granuloma, pretty well defined, well circumscribed in comparison to the rest of the dermis. And here another picture, you see this case is a bit deeper and a low magnification. You have at first the impression of a tumoral process with this nodular proliferation, or indeed granulomatous proliferations. A very common type of granuloma is the foreign body granuloma. Can happen after the presence of own body material, typically keratin, after ruptured folliculitis or rupture of an epidermoid cyst. Can be also due to calcium urate oxalate, or can be foreign body material like suture material, paraffin, silicone, wood plants after cosmetically intervention, or in the case of wood and plants, accidentally. These are examples of foreign body granuloma. In this tattoo, there were a granulomatous reaction on the red color. It's more allergenic than the black color. And this patient had filler injection around the mouth, causing a strong granulomatous reaction that is very difficult to treat afterward. Here you see the granuloma are formed around a foreign body material that is still detectable in the center of the biopsy. It's sometimes difficult to identify. In this case, we suppose it's a piece of wood. And it's the diagnosis is even more difficult if you don't have the corresponding history from the side of the patient. And here you see also the importance of polarization. You see that this rest of suture material is positive with polarized light. And you see here this multinucleated giant cells that are trying to remove the foreign material and causing the granulomatous reaction. In comparison to sarcoidosis, the granuloma are smaller and there is much more lymphocytic infiltration. And here is an example of giant cells with multinucleated. The overficial granulomatosis is a rare disease. It's called also cheilitis granulomatosa. It's important to know because it's part of a triad, the Merkelson-Rosenthal syndrome, characterized through cheilitis granulomatosa, facial paresis, and lingua plicata. You see here the patient has fluctuating swelling of the lips that with the time stays persistent, not like in angioedema. Histologically, there is a normal epidermis like in most of granulomatous disease because it's dermal process, subepidermal edema, and mostly sarcoidal granulomas. This is an example. You see the difference with the skin. This is a mucus biopsy of the lip, so it's not keratinized. It's more acanthotic than the epidermis with pale glycogen-rich cells in the upper part of the epithelium. and these dermal granulomatous formations in the dermis. Another granulomatous disease or a variant of rosacea is the granulomatous rosacea, clinically characterized through telangiectasia, erythematous papules like the classical rosacea, but also with infiltrated more nodular lesions, can be very small, pinpoint. And here you see again this typical granulomatous disease coloration is dark red, brownish. But here around the eye, so here the histology is important to confirm the diagnosis. We find them granuloma in the dermis with mixed lymphocytic inflammation, mostly perifollicular, perivascular with giant cells, telangiectasia like classical rosacea, and folliculitis often with presence. And here you see that normal epidermis and this dense perifollicular inflammation with the lymphohistiocytic and this granulomatous aspect. And we have also the telangiectasia in the upper dermis. And here you see the strongly inflamed granuloma. They're sometimes difficult to see in the important inflammatory infiltrates. We go now to the infectious granulomas. An important disease in the world, maybe not so common in our country, is leprosy. It's caused by Mycobacterium leprae, an obligate intracellular gram-positive and weakly acid-fast organism. The complexity of the clinical presentation is related to the varied immunological response. It's transmitted by nasal discharge or through the skin by scratching. I added the picture of the 7-band armadillo here because in southern states of the United States as well as in Mexico, the armadillo is one of the carrier of leprosy. That's why you shouldn't take the animals that you found in your arms, so you have to avoid to be scratched by them. The incubation period is usually 3 to 5 years, pretty long, can be up to 20 years. So that's why it's not a disease that you just catch up in a 2-week vacation. It's usually in patients that lived for a long time in an endemic region. We distinguish the tuberculoid leprosy in patients with a good cell-mediated immunity. It's characterized clinically through few cutaneous lesions and a strong granulomatous response. The lepromatous leprosy is in patients on the other end of the spectrum with poor cell-mediated immunity, disseminated lesions, and almost no granulomatous response due to the low immunity. The borderline is intermediate between tuberculoid and lepromatous. The intermediate leprosy is a very early form with single skin lesions and no sensory loss. It is important in leprosy to think about the disease clinically when you have depigmentation associated with a loss of sensibility, because the disease is destroying the nerves in the skin. This is the geographical distribution of leprosy. You see this pretty rare in Europe, but there is a very strong prevalence in India, in Brazil, and also in the States, Mexico, and the rest of South America and Africa. These are different clinical pictures of leprosy. So in patients with a low immunity, is characterized by multiple lesions. You see this nodular proliferation can be very mutilating. See here on the hands, can cause also an ectropion, or it can infiltrate the face, and is also characterized by a loss of the eyebrows. on the face. And here you have a single lesions. So without a sensory loss, it's difficult to have an affirmative diagnosis, but this depigmentation associated with the loss of sensory feeling is typical for leprosy. You see here also a few isolated lesions, and other, they look more granulomatous, like small subcutaneous nodules. And here other forms also with the loss of the eyebrows, the depigmentation, and here also the depigmentation on the face with sensory loss. Histologically, the tuberculoid leprosy is characterized through non-caseating granuloma without a grand zone, with inflammation mostly along the nerves, and few bacilli. In most of the cases, because of a strong immunity, it impairs the proliferation of the bacteria. The lepromatous leprosy in patients with low immunity is characterized by diffuse infiltrate with sheets of heavily polarized foamy histiocytes separated from the epidermis by a grand zone and have many bacilli. Borderline leprosy have perineural fibrosis with lamellar or onion pattern collection of epithelioid cells without well-defined granulomas and only occasional bacilli. In the indeterminate leprosy, so the early form have superficial and deep infiltrates in the dermis with lymphocytes with only few macrophages. An increase of the mast cells and the bacilli are difficult to find. So there is a very broad clinical and histological presentation. So if there is a history of the patient living in an endemic region, you have to perform the Zell-Nielsen and Phyt staining to identify the mycobacteria, and also to PCR. Here you have the Zell-Nielsen stain with these small dots. They are the positive staining bacteria, and here you see this superficial and deep granulomatous proliferation. You can think about sarcoidosis, for example. Here the granuloma have very few peripheral inflammation. They're pretty well rounded. And here a form that mimics also sarcoidosis, although in some areas you have a bit more inflammation with this nodular proliferation of large granuloma with nodular involvement of the complete dermis. And here at a closer view, you see this inflamed granuloma. So compared to the sarcoidosis that we saw before, we have more inflammatory infiltrates around. And here you see the grouping of multinucleated giant cells. Another disease now, the leishmaniasis, is caused a skin infection caused by protozoa from sandflies. We distinguish three clinical presentations: the cutaneous leishmaniasis, mostly but not always caused by Leishmania tropica; the mucocutaneous leishmaniasis, mostly caused by Leishmania brasiliensis; and the visceral Leishmania Kala-Azar, mostly caused by Donovani and Infantum. So the form that we see the most here that comes back from vacation with the patient is the cutaneous leishmaniasis due to Leishmania tropica. It's typically in the non-covered acral region because of the sandflies. And here you have the distribution. So the cutaneous leishmaniasis is mostly in the Mediterranean pourtour, but some cases have been detected last years in the south part of Switzerland too. Here is the typical presentation of the cutaneous leishmaniasis, a single lesion on the face. There is first, like an insect bite, a small red papule that is growing and then ulcerating. You have more granulomatous presentation with less epidermal involvement and more ill-defined. And here you have also on the legs with subsequent ulceration. Epidermis can be normal, atrophic, acanthotic, or ulcerated, like we saw in the clinical picture. Histology is characterized through diffuse mixed granulomatous dermal infiltrates of lymphocytes, histiocytes, plasma cells, neutrophils, and giant cells with occasional caseation. And the amastigotes, organism in histiocytes or extracellular, are 2 to 3 microns. Here you see that the epidermis is atrophic, pushed up through this granulomatous proliferation. The upper dermis, but also with deeper infiltrate in the deeper dermis, are filled with this granulomatous diffuse. Here you see an acanthotic epidermis, so completely different than the case before, and you see these bright areas that speaks for granulomatous inflammation. What helps to see that it's granulomatous is this impression of busy dermis and the presence of multinucleated giant cells. And of course, you have to think about it and you have to look much, much more closer at the highest magnification, so 400, and then you will see these very small dots present in the histiocytes. This is the amastigote. Some of them are also extracellular and help also with different stains. You have the GEMSA stains when you see the amastigotes much more better. And you can also stain them with CD1A. Often you have also proliferation of plasma cells that are often a sign for an infectious disease. And finally, we'll speak about tuberculosis. Clinically, there are different modes of inoculation that lead to different clinical presentation. Can be through inoculation, through lymphogenic or hematogenic proliferation per continuitatem, that means directly next to the site that's already affected. And then we have also the tuberculitis. The skin lesions that are not directly infested with the mycobacteria, but they represent an immunologic reaction to the disease. So these are different clinical presentation. You see this patient with broad erythematous squamous plaques and some nodules on the face with the scales. That's why you wouldn't think immediately of a granulomatous disease. Can think about psoriasis, but then it will stay more in the area of the hair. Some other can also mimic chronic lupus or sarcoidosis. But we can help us also with the diascopy and this apple jelly color. And this is an example of erythema nodosum. So tuberculate, you don't find the bacteria in the lesions. Lupus vulgaris is the presentation of tuberculosis in the skin. The epidermis is atrophic or acanthotic with papillomatosis, sometimes ulceration. The adnex are sometimes destroyed through the granulomatous inflammation. And the dermis, you see granuloma with epithelioid cells, giant cells from Langerhans type, many lymphocytes, and a frequent central necrosis that is typically for tuberculosis. And of course, you need supplementary investigation to confirm the presence of tuberculosis. We don't have a picture in our collection. That's why I present you a picture from the textbook from McKee. You see again this very busy dermis with some lighter zones. There are the zones rich in histiocytes and the central caseation necrosis that we don't see in the other diseases. And the stain, the Zil-Nielsen, that allow us to see the microorganism. And mycobacteriosis that we see more in our country is caused through Mycobacterium marinum, present with a sporotrichoidal pattern of the skin lesions, is due to a contamination of people that have an aquarium through small wounds in the skins. The histology is characterized by an acanthotic epidermis with papillomatosis and a mixed inflammation in the dermis with many neutrophils, epithelioid cells, giant cells, and sometimes caseation. It helps when it's. So these are some clinical picture of infection with Mycobacterium marinum. You see often on the hands, with of course this granulomatous aspect, but often with acanthosis, ulceration that can mislead the clinician. You see the sporotrichoid pattern. This patient had an infection on the nose. And you see often you also have, besides the typical granulomatous proliferation in the dermis, you also have epidermal changes. And again, this is a histology from the textbook. You see this strong epidermal reaction with acanthosis, papillomatosis, pseudocarcinomatous acanthosis, and inflammation in the upper dermis that's not evidently granulomatous because of the proliferation of other cell types, but you can see a few giant cells. So it's important to think about going to look for the. Thanks a lot for your attention. If you look in the literature, in the textbooks of dermatology about neutrophilic and eosinophilic dermatosis, you have a list like you see here now. You see that most of these cutaneous diseases are pretty rare, like, for example, the neutrophilic dermatosis associated with gastrointestinal disease, or cutaneous atypical neutrophilic dermatosis with lipodystrophy, or the incontinenza pigmenti, important to know, but very rare. So I decided, while talking about all this zebra, I want to concentrate on the horses, so on the common thing. And I wanted to present you how do we think when we see a neutrophilic dermatosis, how we proceed. So when we see neutrophils, then we look first, where are they located? For example, in the epidermis, we think immediately about tinea and impetigo, psoriasis, pustular drug reactions, and subcorneal pustular dermatosis. If it's subepidermal, then we think about dermatitis herpetiformis, linear IgE dermatosis. Dermal, you have to exclude an infection. And then you have the large group of the neutrophilic dermatosis, among them sweet, pyoderma gangrenosum, and further. The subcutaneous disease, of course, every time you have neutrophil, you have to think about infection and exclude an infection. The alpha-1 antitrypsin is also rich in neutrophils. Then, of course, the folliculitis, here again, infectious or sterile.
And then we have also the vasculitis, leukocytoclastic vasculitis, septic vasculitis. And now I will present some entities that are characterized through infiltrate of neutrophils. Some of the diseases have been presented or will be presented also in other courses of dermatopathology essentials, but I think it's important also to have some repetition to learn things. With neutrophils in the epidermis, you have to think about tinea impetigo, exuded infection, and then psoriasis and pustular drug eruption like agap. Here is the histological counterpart of the dermatosis I just mentioned. And you can see in tinea, the neutrophils in the stratum corneum, impetigo, also very superficial. Psoriasis, there is the neutrophilic abscess in the epidermis, and the subcorneal pustulosis of agap. I will go in detail with these entities later. Then, if the neutrophils are localized in the dermis, we think about sweet disease, urticaria, pyoderma gangrenosum, neutrophilic urticarial dermatosis. Urticaria is actually a disease that's characterized through infiltration of neutrophils and eosinophils. So I mentioned it in both talks. And here again, you can see also at this remote view that neutrophils are infiltrating the dermis, that in most cases, the epidermis is unaffected by this disease. Also important to remember the definition of a collection of neutrophil is an abscess. It can be sterile or infectious. The infectious causes are mostly folliculitis or a furuncle. Sterile abscesses are seen in psoriasis, agap, pyoderma gangrenosum, dermatitis herpetiformis. An important clue too, if you see neutrophils, especially in the epidermis or the superficial dermis, always look first for an erosion. If you have an eroded skin, you will have reactive neutrophilic infiltrates. It doesn't make neutrophilic dermatosis immediately. Tinea is a very important diagnosis. We do PS staining for every infectious, so every inflammatory dermatosis to exclude this this diagnosis. So the neutrophil are sometimes localized in the stratum corneum. We often have parokeratosis, and a typical sign is the sandwich signs that you see represented here. You have an orthokeratosis or parakeratosis. Orthokeratosis is normal keratosis. Parakeratosis is when the nuclei are retained and can be seen in the stratum corneum. They alternate with basketway stratum corneum. This is a clue for the presence of hyphae. Of course, you need them. You can see them sometimes in H&E, but they are better seen with the PES. The other changes in tinea are very variable. In the epidermis, you can have a spongiosis, intradermal vesicles, psoriasiform dermatitis, sometimes a folliculitis. In the dermis, it is the same. Sometimes you have an almost normal H&E, sometimes perivascular or diffuse infiltrates with lymphocytes, histocytes, neutrophils, but also sometimes eosinophils. That's why the study of the stratum corneum and the PAS stains are fundamental. Here I have an example with the PAS stain, the PAS positive hyphae in the stratum corneum, the exocytosis of neutrophils, and a parakeratosis that's not clearly seen here. And here is the invasion of an hair follicle. You see here the hair shaft that's completely invaded with the hyphae and the hair follicle. And there is a perifollicular inflammation. So you have to do recuts and to be lucky that your PS stains is corresponding to the section of the hair follicle for this diagnosis. In impetigo, you often have a lot of epidermal reactions, bleeding, crusting, and you can even see beside the pustule, these are all neutrophils in the epidermis and the superficial dermis. The bacteria itself can be seen also without the gram stain. This is this kind of dirty violet stain that you see in the bulla. But of course, it's better to do a gram stain to confirm. And you have also very marked spongiosis here, and superficial perivascular lymphocytes and neutrophils. When we describe the histology, we almost always describe lymphohistiocytic infiltrates because we rarely have purely lymphocytic infiltrate. So standard infiltrate in histopathology has always a certain quantity of lymphocytes and histiocytes, and on top of them, then we look for neutrophils or eosinophils, for example. Psoriasis, also important to know, it's characterized through a confluent parakeratosis, not only focal like in eczema or other dermatosis. There is a hyperkeratosis, neutrophil in the stratum corneum and in a spinous layer. They have different names. Also, this is the same mechanism. There is the exocytosis of neutrophil in the epidermis. Under this, we have the hypogranulosis, thinning of the epidermis, a regular acanthosis, dilated capillaries in dermal papillae, and this causing the Auspitz sign, this pinpoint bleeding if we scratch the scale off. And perivascular lymphocytes and neutrophils, especially in the beginning, in established lesions, are some often missing. And the pustular psoriasis with subcorneal pustules, and it's difficult to distinguish from agate, for example. So here we see this confluent parakeratosis covering the whole epidermis, the reduction of stratum granulosum, not everywhere. For example, here is conserved, here too, but here is reduced. The acanthosis, so a thickening of the epidermis, and neutrophilic infiltrate. This is a pretty early lesion. You see that we don't have this typical psoriasiform acanthosis with a thinning of the suprapapillary plates. So we really have all the criteria in one biopsy, especially if it's very typical psoriasis, maybe the clinician won't biopsy it. Here you have a more evolved psoriasis with this suprapapillary thinning, these thin elongated red ridges. They're all about the same length. This is the psoriasiform acanthosis and the neutrophils in the stratum corneum. The acute generalized exanthematous pustulosis, AGEP, will be also discussed in the talk from Dr. Gadaldi. So just one picture to see the histological presence of these subcorneal pustules. You see that the epidermis is complete intact. The pustule is in the stratum corneum, and always in drug reaction, presence of necrotic keratinocytes is a good clue. And we have perivascular infiltrates of neutrophils, but also of eosinophils. Here we see a bit better the eosinophils and the neutrophils. Sweet syndrome is a typical neutrophilic dermatosis. It's characterized through an acute onset, painful dark red plaques or bullae, especially on the face and extremities, with fever, leukocytosis, and systemic symptoms. It's important to exclude an infection and to look for an internal malignancy. And here I listed, just to remember them, the criteria for the diagnosis of Sweet syndrome. You see that one of the two major criteria is the histopathology consistent with Sweet syndrome. And the histology of Sweet is pretty characteristic. You have a massive edema of the papillary dermis that is pushing the epidermis up. You see that the epidermis itself is not damaged, can show a small discrete spongiosis, but is usually pretty normal. And you can imagine that if the edema of the papillary dermis is very important, it can push the epidermis up so that it comes to the formation of blisters and bullae. So it's always a question when you have a bullous disease, how is the bullae has been created. So it can be either through subepidermal or intraepidermal dissociation of the cells, like in psoriasis or bullous pemphigoid. It can be like here through a massive subepidermal edema. The blisters can also come from a massive spongiosis. Here you see also the diffuse dermal neutrophils that are typically superficial but also deep in the tissue. And often we always have lymphocytes, histiocytes, and sometimes eosinophils. And here you see also extravasated erythrocytes. So there are often extravasated erythrocytes, also nuclear dust. So this is the small dots, that's the resulting from the degradation of neutrophils, but usually no true vasculitis. Pyoderma gangrenosum is also one of the typical neutrophilic dermatosis, so a non-infectious neutrophilic disease. And there are a lot of different criteria for Pyoderma gangrenosum. These are the most recent criteria for a publication in 2018 in JAMA after Delphi consensus. And you see that the major criterion is biopsy of ulcer H demonstrating neutrophilic infiltrates. It's important to remember that Pyoderma gangrenosum is not a histological diagnosis. You see that the clinic is also essential, and you have to have the clinical course also, because histologically it's not possible to distinguish Pyoderma gangrenosum from an infectious ulceration, for example. So usually, depending on where the biopsy has been performed, you see the epidermal necrosis or ulceration. Is often difficult to see this undermining under the epidermis, because you have to have the perfect cut of your histology and the perfect place of the biopsy. Often you have this massive acanthosis of the epidermis, so pseudoepitheliomatous hyperplasia that is purely reactive, and in the dermis, massive infiltrates of neutrophils, lymphocytes, and histiocytes. And here you have also some hemorrhage, so extravasated erythrocytes. So most we can tell with such an histology is compatible with Pyoderma gangrenosum if the clinic fits. But it's not a diagnosis that the dermatopathologist will make for the clinician. We go now to a bit more rarer dermatosis, but maybe important to know because it can be the marker of an internal disease. The neutrophilic urticarial dermatosis is a particular manifestation in different autoinflammatory disorders. Can be seen in Schnitzler syndrome, Still disease, cryopyrin-associated periodic syndrome, but also in autoimmune disease like in lupus, rheumatoid arthritis, Sjögren, and in monoclonal gammopathy and IgA myeloma. Clinically, you have pruritic pale erythematous macules, papules, or plaques that, like standard urticaria, move and resolve during 1 to 3 days. Histologically, like in urticaria, you have a normal epidermis. It's a dermal disease, and you have perivascular and interstitial infiltrates of neutrophils, also similar to urticaria, but you have also leukocytoclasia without vasculitis. So in the surroundings of the vessels, you will see these small dots. These are the degraded neutrophil granulocytes, but no true vasculitis. So it's a often very discrete finding in the histology. Here again, you need the clinic to lead you to the diagnosis. And then I will present together the histology of the linear IgA bullous dermatosis and the dermatitis herpetiformis, because they cannot be distinguished histologically without the direct immunofluorescence. So the linear IgA bullous dermatosis is a rare disease, idiopathic or drug-induced, with a linear deposition of IgA at the dermoepidermal junction. So it, from the clinic and the histology, is very close to dermatitis herpetiformis, but without the gluten-sensitive enteropathy. And the patricular forms are the childhood form of the disease called chronic bullous dermatosis of childhood, and the drug-induced linear IgA dermatosis that is often induced through vancomycin. And here you see the clinical picture with fresh lesions. They have these annular vesicles, partly confluating, and here a bit an older lesion already with a post-inflammatory hyperpigmentation. And both diseases, so LABD and dermatitis herpetiformis, are typically characterized through presence of neutrophils in the dermal papillae. So this is microabscess, and often perivascular lymphocytes, neutrophils, and sometimes also eosinophils. And if you're lucky, you see here the beginning of the subepidermal blister. But for example, in the literature about dermatitis herpetiformis tells that these neutrophil microabscesses are present in less than 30% of the cases. So in about 50% of the cases, you have a non-typical histology that's not contributing. And here again, you see that these neutrophilic abscesses have also a few eosinophils. And here again, so they are located in the dermal papillae. Also a pretty rare disease is IgA pemphigus. Is a rare variant of pemphigus with a relatively benign course compared to the other pemphigus, with a good response to dapsone, like most of neutrophilic dermatosis, usually no mucus involvement, and characterized through intercellular IgA deposition, like classical psoriasis, but with IgA. And we distinguish two subtypes. The subcorneal pustular dermatosis is the pendant, the IgA pendant of pemphigus foliaceus, so the superficial form, and the intraepidermal neutrophilic IgA dermatosis variant. This is the IgA correspondent of pemphigus vulgaris. It's usually a very pruritic disease, and important to know that about 20% of the patients have a monoclonal gammopathy of the IgA class that need to be excluded. And you see here this typical aspect of the pustules with an hypopion. So the neutrophils are accumulating in the bottom of the bullae due to gravity. The histology is a bit different between both types, of course. And SPD, you have vesicles in a subcorneal location, like we saw already, like in pustular psoriasis or AGAP or Snedden-Wilkinson, for example. They all have similar histology. In the IAN, the pustules are through all layers of the epidermis and also in the hair follicles. But acantholysis is not always obvious, so it's difficult. You have to think about it to look also for the direct hemofluorescence. You can have also neutrophil microabscess, neutrophil spongiosis, and infiltrate with neutrophils and sometimes also eosinophils. So this is an example of the subcorneal pustular dermatosis. You see that the epidermis has a acanthosis, but the clefting is in the stratum corneum, and you have this massive pustule with also island of acantholytic cells. Another example, and here the other type, the intraepidermal, you see here this intraepidermal acantholysis that is also concerning the hair follicle. So if you have only this part of the histology, if you don't have the clinical or the direct hemofluorescence, it's impossible to make the diagnosis between the other acantholytic dermatoses like Grover, Haley, and other pemphigus. And here is another example with this suprabasal and intraepidermal acantholysis. Dermatosis. And here again, when we see eosinophils in a skin biopsy, we will look first where they are located. epidermis, we have to think about eczema, bullous pemphigoid, incontinent subpigmenti. If it's subepidermal, like we saw before, dermatitis herpetiformis and linear IgA dermatosis can also be characterized through presence of abscess of eosinophils. If it's dermal, then we have to think about infection. That's what we call arthropod bite reactions, Wells disease, reaction to drug, and if it's on the face, granuloma faciale. Subcutaneous exclude an infectious panicolitis. The alpha-1 antitrypsin panicolitis can also be characterized through eosinophils and the eosinophilic fasciitis that I will present this afternoon in the talk about collagen disease. Of course, if it's in the hair follicle, folliculitis, the eosinophilic folliculitis, and vasculitis. And here again, we find the same diagnosis that with the neutrophilic dermatosis, leukocytoclastic vasculitis, and urticaria. Basically, when we see eosinophils, you always have to exclude or to think about arthropod reactions, or insect bite reaction, and about drug. So here you have the common one. This is characterized through eosinophils and presence of spongiosis. When we see this picture, we have a superficial dermatitis with acanthosis, spongiosis, superficial inflammation with eosinophils. We think, okay, it's spongiform plus eosinophil. We automatically think about eczema and bullous pemphigoid. Of course, if the patient is a baby, then you have to think also about incontinentia pigmenti. If we have the presence of eosinophils in combination with acantholysis, then the most common one is Grover's disease, but you have to think about also about pemphigus vulgaris. If you have interstitial eosinophils, then, as I mentioned before, insect bite reaction or reaction to drugs. If you have massive infiltrate of eosinophils, then Wells syndrome, and always also if you have perivascular infiltrate, urticaria. And here the corresponding that we'll see one after the other. So eczema is, of course, the most common eosinophilic rich dermatosis that we see in our daily routine. If you have some clinical picture that illustrate why it's sometimes difficult for the clinician to find the correct diagnosis because of the polymorphous presentation. And I have to say that from the histology, it's pretty difficult to give indication about the subtype. So, of course, for this hydrotic dermatitis, we'll see sometimes the dyshidrosis and the vesicles in the epidermis. But to distinguish between allergic contact dermatitis, an Yt reaction, or atopic dermatitis is almost impossible in the histology. There are a lot of publications looking for specific clues for the different diseases, but the clinical pathological correlation is essential. In a typical biopsy of eczema, you have this focal parakeratosis. This is here continuing, but it was stopping and starting again. You have an acanthosis of the epidermis and a spongiosis that it's not always generalized. The whole epidermis can be also localized, like in this case, and you have superficial infiltrates with lymphocytes and eosinophils. Here you see a bit better the spongiosis with desmosomes between the keratinocytes and the superficial infiltrate with the presence of eosinophils. Concerning the eosinophils, usually we learn that psoriasis, for example, doesn't have eosinophils. It's not completely true. We have some biopsies with really a mixed presentation of psoriasis and eczema. For example, we have a continuous parakeratosis, a hypogranulosis, but also spongiosis and eosinophils, and we cannot help the clinician further than telling him it might be a chronic eczema, but it might be also psoriasis with eczematous changes secondary. And here you have the other aspect. This is dysheterotic eczema. You see the spongiosis is so massive that it led to the formation of vesicles in the epidermis. And you have, of course, the spongiosis in between all these vesicles. And you can imagine here too that if these vesicles start conflating, that you can also have a blister. As I mentioned before, this one possible mechanism of blister formation. You see that the spongiosis is also involving the hair follicles. And I said before, the infiltrates are superficial, and you see here the variation of the theory. In these cases, the infiltrates are not only superficial, they go also along the hair follicle and in the deeper dermis. So it's also possible to have deeper infiltrate if the reaction is very strong. Here we see these intraepidermal vesicles. You sometimes have the exocytosis of eosinophils in the epidermis, and then you find them in the vesicles, the massive acanthosis and the spongiosis. And this infiltrates with lymphocytes and eosinophils. Of course, the main differential diagnosis for us with spongiosis and eosinophilic rich infiltrate is the bullous pemphigoid. And the histology is pretty clear when you have already the subepidermal blister that's visible on the histology. But about 2/3 of the biopsy we get with the question of bullous pemphigoid, they don't have the blister. They are still in the urticarial phase, and then it's of course more difficult to find a diagnosis. So you always have to think about it: spongiosis, eosinophils, maybe exocytosis of eosinophil in the epidermis. You have to have also direct immunofluorescence to exclude a bullous pemphigoid. Here again, you have a compact hyperorthokeratosis, a discrete acanthosis that is here more massive, and a spongiosis. And here you will tell me, but this is intraepidermal. We see the basal layer of the epidermis. We see here the keratinocyte. So it's not the subepidermal vesiculation. Here is intraepidermal. And it's also possible because, as we said before, between this transition of the urticarial and the bullous phase, we have a transition between intraepidermal vesicles and subepidermal blister. So this was a bullous pemphigoid. But it could be also, depending on the clinic, dysheterotic eczema. And you see here this massive infiltrate of eosinophils. So when you have hundreds of eosinophils, you always have to exclude an autoimmune bullous dermatosis. Here is the urticarial variant of bullous pemphigoid, or pre-bullous, that is sometimes called, but that don't all go to bullous form. That's why we call them more non-bullous bullous pemphigoid. And you see here the epidermis is completely unspectacular. We just have this massive infiltrates with eosinophil granulocytes. So this is always also a sign for bullous pemphigoid. And here another histology, and you see the formation of a subepidermal blister. Here too, it's sometimes difficult to see where is the important information in the slide, because we have also a massive acanthosis and a formation of crust and bleeding. Then a very common disease, but there is a bit underdiagnosed, is the Grover disease. Is acquired self-limiting acantholytic disease of unknown etiology, principally of the middle age or elderly, with a predilection for the winter. The lesions are polymorphic, usually 1 to 3 millimeter erythematous, red, brown, or skin-colored papules, vesicle, eczematous plaques. What helps the most, I think, is the clinical indication of sun exposition or a bedridden patient, and a predilection for the chest and the back. So it's favored by sun exposure, sweating, radiation, and drugs. The histology of Grover disease might be challenging because it can mimic other diseases. The most common type is like Darrier, but here, of course, the clinic will help us making the correct diagnosis. It can also have more acantholysis, like in Haley-Haley, or it can lack completely this keratosis, like in pemphigus. So typically, you have a acantholytic disease with superficial infiltrate of eosinophils, and you have usually also this keratosis. So the acantholysis is the loss of cohesion between keratinocytes, and this keratosis is following. This is a abnormal cornification of the keratinocytes below the stratum granulosum when it's usually happening. And usually the eosinophils are helping us for the diagnosis. So you see here in this acanthotic epidermis, this clefting, that is a suprabasal acantholysis. But here, for example, this keratosis is not very marked. Here you have maybe 1 or 2. And this infiltrates with eosinophils and neutrophils. So if we get one histology like that, we cannot make the diagnosis of Grover right away, but we can tell that as is the commonest acantholytic dermatosis, that is our main suspect, that the clinician has to exclude the other acantholytic dermatosis. Here another example, you see here the basal layer of keratinocytes, and you have this suprabasal acantholysis, and here the dyskeratosis is more marked. So all these cells that have lost the connection and they start getting rounded. And here again, the infiltrates with eosinophils, not only a few here. The brown dots is the pigment incontinence that can occur through interface dermatitis or any damage to the epidermis. Then, of course, pemphigus. Have some clinical picture. So if you have a skin involvement, don't forget to look for the mouth and the other mucous sites. The pemphigus is characterized through eosinophilic spongiosis. So in the very early stages, you can have also an histology like I showed before for the non-bullous pemphigoid or for eczema. And then you have this suprabasal blister with acantholytic keratinocytes. So they are rounded, eosinophilic, so pink, with pycnotic nuclei, or very small nuclei, and a perinuclear halo, and a few eosinophils or neutrophils. And the typical pattern is this tombstone pattern that we'll see in the picture. And if you see an acantholysis in the adnexal structure, is also a useful clue. And this creates inflammation, often with eosinophils. And just as a reminder, in pemphigus vulgaris and pemphigus vegetans, the blister are of suprabasal location, whereas in pemphigus foliaceus, erythematosus, and Fogo-selvagem, the blisters are more superficial. They're under the stratum corneum. So this is a typical picture of pemphigus vulgaris. You have this suprabasal blister with all this acantholytic keratinocyte. They are free floating, and the one that remained attached to the dermis, they are aligned in a single layer, and it's like a cemetery, like this tombstone disposition. Here another example with a typical tombstone pattern. Depending where the biopsy has been taken, which is just in the middle of the blister, of course, the epidermis will be lost during the preparation, or at least separated completely from the dermis. And here you see also the acantholysis of the adnexal structures, and a few infiltrates. Is not very inflammatory in this form. You see that you have to look at the whole biopsy, because here you have this typical suprabasal acantholysis, but here, for example, if you had only this part, it's difficult to tell if it's suprabasal or intraepidermal. So it's, you have to observe the whole biopsy. And here again, another example, have to imagine if you're at the border of this biopsy and you have only these few keratotic cells and you have no clefting, the diagnosis is difficult. It becomes clear here maybe, and more. And compared to a Grover, for example, pemphigus is characterized through much more extended acantholysis, and you see here in the clinic too, in pemphigus you have bullae, whereas in Grover usually you have smaller lesions without bullae. And you see also at this magnification the infiltration with a lots of eosinophils, perivascular, but also interstitial location. And we say that typically in pemphigus you have acantholysis without dyskeratosis, but these are clear dyskeratotic cells, so they have this pycnotic nuclei, they are rounded, they are going into apoptosis. So that's why these histological criteria are not always 100% sure, and we have to stay very open with a histological diagnosis. Here is the marked acantholysis speaking for psoriasis. And here, of course, the correlation with the direct immunofluorescence is fundamental. Here again, an example of the tombstone pattern, and you can see the eosinophils in the infiltrate everywhere, even in the epidermis. And here also the involvement of the hair follicle adnexal structures with erythrocytes here. An important pattern with eosinophils is the arthropod bite reactions or insect bite reaction, Often we have an epidermal reaction with a crust, necrosis, hyperplasia, depending if we are just where the insect attacked the skin or if we are more distant. And we can have also epidermal reaction with spongiosis or intraepidermal vesicles, often a dermal edema, subepidermal vesicles, and typically superficial and deep infiltrate with eosinophils. And this is an example. We are already in the deep dermis, and you see the infiltrates are going up to the fat tissue. So this lacunae is the fat tissue, and you see this massive infiltrate with a lot of eosinophil granulocytes. And we say that typically the infiltrates are wedge shaped, so they are broader in the upper dermis than in the deeper dermis. And here again, to see the infiltrates with the eosinophils, so there are almost as much eosinophil as lymphocytes, so there are lots. And of course, sometimes you are lucky and you see also the agent directly in your histology. It's rare, but here you see the scabious mite in her channel, and acanthosis, a reactive acanthosis of the epidermis, and here also the infiltrates of the complete dermis with a lot of eosinophils. Like in every histological diagnosis, the life of the lesions is important, means there is a certain dynamic. And when I was in Houston and the school of Professor Rapini, he told us that he saw sometimes stench biopsy, so insect bite reaction with neutrophils, and he was convinced that the early reaction are characterized through neutrophilic infiltrate, that the eosinophils are coming later. So the next time he was stitched by a mosquito, well, it's very common in Texas, he let a resident biopsy the lesion, and it was filled with neutrophils without a single eosinophil, what was confirming his supposition. But usually when a patient comes to us, is already in the eosinophilic rich stadium. The drug reaction, I just wanted to mention them because as soon as you have a few eosinophil, or if you have a lot of eosinophil, you always have to think and exclude a drug reaction. In the maculopapular rash, in agap, in the lacinoid drug eruption, eosinophils are always a clue for a drug reaction, but this will be explained further to Dr. Gadaldi a bit later today. The Well syndrome is a typical eosinophilic rich dermatitis, is the pending of sweet syndrome, characterized by bright red, painful, non-infectious indurated plaques, sometimes with blister, resolving in some days, sometimes some weeks, even with peripheral eosinophilia. The histology, of course, characterized through dense dermal infiltrate with eosinophils, with the typical dermal flame figures. These are this bright eosinophilic area of collagen encrusted with eosinophilic granules. If you see them, it speaks for Well syndrome, but of course, they are not specific for Well syndrome. As soon as you have a lot of eosinophils, you can have these flame figures. So here you see the histology with a complete normal epidermis and this dense perivascular infiltrate with lots of eosinophils there as well, superficial but also deep. We go a bit closer. They go even to the fat tissue, and you see this red zone. So from this distance, you cannot tell if these are erythrocytes, extravasates, or crushed eosinophils. And here you see that these are all eosinophils confluenting, and we see even better in the next picture that you have the infiltrate with the eosinophil that melt and degranulate and make this flame figure in the collagen. And you see there are also a lot of neutrophils. By the way, all the small dots, this is leukocytoclasia. And urticaria, characterized through normal epidermis, a discrete dermal edema, and sparse pervascular infiltrate with eosinophil and neutrophils. It's important that you have an intact epidermis. We see here again the pervascular infiltrate with eosinophils. And granuloma faciale is an uncommon idiopathic brown red plaque on the face of adults. It's pretty rare, but I had to mention it here in the eosinophilic dermatosis because often it's misdiagnosed. Of course, not a very specific histology. You can think about a lymphoma, BCC, or other tumor disease. It's characterized through a dermal proliferation of eosinophils, superficial and deep infiltrates, normal epidermis, and a grand zone. So the first impression would be of an infection or a lymphoma. You see this massive infiltrate of eosinophils, and the name is a misnomer because there are no granuloma in granuloma faciale. Here we see a bit closer the grand zone and the diffuse inflammation with the eosinophils, also neutrophils, lymphocytes, histiocytes. You know, of course, that we are on the face. You have to think about this diagnosis. Sometimes you have also leukocytoclastic vasculitis and hemosiderin, but they're not obligatory. Thank you for your attention.
Good evening, everybody. So this was the 4th edition of the Dermatopathology Essential. This is a new conference since a couple of years that in 3 years is summing up the whole dermatopathology, mostly for residents in dermatology and in pathology. This year, we begin a new curriculum of 3 years. We began with inflammatory diseases. I say a big thank to Heather Dawson, Peter Heusermann, Andreas Volz, Beda Mühleisen, and Laurence Fellmeyer for the lectures. Another big thank goes to Laurence Fellmeyer for the co-organization, and a big thank to Tamara Gerber for the administrative part of the organization. I'd like also to say thank you to DocFix that organized the whole streaming of this event. All of you will have the possibility to see again the lectures in the next days, and please make questions to the lecturer and they will answer you by email. So use the question platform and they will answer you by email. I hope you could learn a lot from this event. See you next year with the second part of this new curriculum of 3 dermatopathology essential, where we will cover again the whole dermatopathology. See you next year and have a nice evening. Bye-bye.